one for publication, one for synopsis renewal, and one for presentation renewal, right? So you write your names for the publication renewal paper, assessment paper, and give it to me here. We'll request everybody to be seated, please. Exit candidate on this side and the synopsis presentation candidate on this side. The new batch on this side and exiting candidates on this side, right side. Hello. Please come forward here.
Good morning, everyone. So we are here for exit event of 5th batch and induction of 6th batch. I'll be very happy in announcing that there are 7 candidates for today's exit exam. And I would like to welcome Dr. Arijit Shah to come and present his details of his publication. Dr. Arijit Shah.
Good morning, my teachers and fellow colleagues. Now I am going to present my publication. My publication is use of biomarker in prognosis and monitoring of disease activity in rheumatoid arthritis in common clinical practice. Rheumatoid arthritis is a chronic inflammatory multisystem disorder that involves autoimmune diseases. Synovial joint damage are most common, leading to inflammation, pain, and later into disability. If we look into the pathogenesis, there is an unknown trigger that promotes inflammation at synovial membrane, and it goes to autoreactivation of the CD4 T cells, leading to resulting the release of pro-inflammatory cytokines. Cytokines like MMP and rank ligand are produced by fibroblasts. The rank ligand causes the osteoclast activation and joint destruction, and where the MMP destroys the tissue, resulting in overall joint damage. So the resultant disability leads to loss of work, decreased quality of life, and there is also a burden in our socio-economic life. In 2010, rheumatoid arthritis classification criteria developed by ACR and Euler put emphasis on history, physical examination, and biomarkers. So in our common clinical practice, we found rheumatoid factor is one of the biomarker, which is a IgM antibody targeting the Fc portion of the IgG, forming an immune complex that promotes the inflammation. There is a anti-CCP2, which is a member of ACPA community, and excellent. It shows excellent diagnostic and prognostic value. There are inflammatory markers like CRP and ESR, And one of important is DAS28 score. And this is a disease activity score of with including 28 joint. It includes 28 joint of upper limb, including PIP, proximal interphalangeal joint, metacarpophalangeal joint, wrist, elbow, shoulder, uh, and knee, excluding hip and ankle, and the lower joint of the foot, small joints of the foot. And along with there is a ESR or CRP and another general questionnaire that provides the general health of the patients. So if we look at to the DAS score, it shows less than 2.5 that patient is in remission. 2.6 to 3.2 it's a low level activity. More than 3.2 it's an active disease, and more than 5.9 very severe disease. So in our methods we put together 27 RA patient, of which we lost follow-up of 2 patients. Average follow-up period was 10 months, and it's an institution-based prospective study. The inclusion criteria was active rheumatoid arthritis as per 2010 ACR or EULAR criteria. Patient managed through OPD without any severe comorbidity on oral DMRD. We excluded those patients who are in injectable DMRDs and patients on clinical remission or IPD patients. So in result, the mean age of the patient was 45.57, 6 were male and 19 were female. Morning stiffness on presentation was 80.23 minutes. Positive family history found in 11 patients. Comorbidities, which is the most common, is hypertension found in 11 patients, and diabetes mellitus found in 9 patients. These are the values of biomarker at presentation and during treatment follow-up. ESR, CRP, R factor, anti-CCP, and DAS28 score are measured. So this is a graphical representation. On discussion, there is an exacerbation of symptoms on acute presentation is commonly presented with elevated CRP and ESR. It is most commonly found. Our post-treatment average CRP is 8.36 and ESR is 37.85. If we correlate with the other study, there is a study of Srivastava et al. She shows that the level of CRP significantly increased in RA cases. It's 8.58 plus minus 5.99, which correlates with our results. In systematic review of 23 studies in 2020 and 2021 by Abdullah Fiz D et al., CRP shows more than 7.1, shows poor outcome. If these cases are presented, is consider regimen changes or addition of oral or systemic steroid. Elevated ESR is better predictor in early rheumatoid arthritis, whereas CRP in a late stage. The shortfall is ESR or CRP is normal in 40% of those patients, and sometimes value may remain stable despite of clinical improvement with treatment. In our study, RA factor decreases from the level of 67.22 to 48.5, far above the normal level though inconclusive, but it provides some indication on the prognosis, rather poor one. Serial monitoring of RA factor is not at all recommended. 30% of patients may present with seronegative rheumatoid arthritis. Presence of seropositivity influence some treatment like biological DMRD in a B cell depleting monoclonal antibody like rituximab. Anti-CCP is more specific. High value anti-CCP having aggressive disease are frequently complaining large and small joint pain. Patient with high anti-CCP is associated with increased risk of joint disease. High titer in anti-CCP shows better clinical response in biologics like rituximab and abatacept. In patients with CSDMRD, it is seen that a presence of anti-CCP with any other factors like rheumatoid factor positive or high CRP that shows poor outcome, and joint damage is far more comparing to the other patients. So DAS28 score, we evaluate for rheumatoid arthritis burden. It's a strong association with anti-CCP and the rapid radiological progression of the joint erosion. In our study, DAS28 ESR was average 3.5, which is suggestive of moderate disease activity at presentation. And after that, on treatment, it shows 3.1, which is suggestive of low disease activity. MBDA correlates with DAS28 score, but the disadvantage of the DAS28 is it is inconsistent and reliability is an issue. So in conclusion, we can tell that biomarker correlates with the disease activity and acts as a potential predictor of response to the treatment. High titers of RA anti-CCP along with CRP can useful as a prognostic marker in clinical practice, but they also included as a diagnostic marker also in criteria. DAS28 score along with SDI or CDI can be act as a tool of monitoring the disease activity. But the problem of the studies, the targeted synthetic DMRD studies with correlation are not available in our study. 14-3 eta protein, MBDA, these are better biomarkers as per the journals, but not easily available right now in our common clinical practice. And this is a short follow-up. Thank you.
Yeah, thank you so much. So you have mentioned that NTCCP, RA factor have a prognostic value, right?
Yes. Yes,
and
sir.
in your work, you have also mentioned that CRP, the level of CRP, the study which was done in 23 individual. Can you elaborate it more? I mean, what is the significance of high CRP, and to which level after which it is more significant?
Study in our study and with correlating with the other study, we found more than 7 or 8 is high CRP is usually significant, and it is usually associated with joint damage because it's due to inflammatory cascade reaction and leading to poor outcome in those patients. So we have to manage this patient to decrease the inflammation more. This patient.
Fine, thank you. Fine, thank you,
sir.
Yeah, next one. We want the paper who is going to get the evaluation done. You, we need your paper.
Thank you very much, Arjit.
No.
Recently, a lot of work is done on another new biomarker, anti-CARP. So you should study about that anti-CARP also.
See,
Just for knowledge purpose.
Yeah, sorry. Every file has got few papers which have been attached to it. Name of the presenter to be written and submitted here to us. So next is Dr. Hardik Kharbanda.
Dr. Hardik Kharbanda.
We'll do evaluation in the form. Here we are going to discuss on the publication which you have made. Then we have two tables inside. In one table, we have a case discussion. In the other, you'll have your synopsis, whatever you have brought with you, with your seminar, whatever it has been done, that will be going to discuss, right? Is it clear now? And is anybody having a laptop also? I've requested, fine. So it will be better that all the cases which you have presented throughout the year should be loaded in the same laptop. So that has to be done there. Right now here we are just discussing the publication part, right? Thank you. ये सब भाई आपको बताया ना, अभी सुना ना आपने क्या, ये अभी क्यों दे रहे हैं? Yeah, please.
Good morning, everyone. Good morning, sir. I am Dr. Hardik, and my publication was on an effect of DMARD therapy on inflammatory biomarkers and disease activity in rheumatoid arthritis. It was done under the guidance of Manisha and Dr. Partha, sir. So the learning point and the study objectives were that the DMARDs are effective in reducing the inflammation and disease activity in rheumatoid arthritis. Key biomarkers such as ESR, CRPs are the reliable indicators for monitoring the treatment response. So the objective of the study was to evaluate changes in the inflammatory markers and the disease activity indices, such as DAS28 score, simplified disease activity index, and clinical disease activity index, before and after the treatment of DMARD therapy in a rheumatoid arthritic patients. So understanding what is rheumatoid arthritis. So it is a chronic autoimmune disorder which is affecting the joint and systemic organs. We know that it causes persistent synovial inflammation leading to the joint destruction, pain, and disability. Pathogenesis involved is the immune dysregulation, T cell and B cell activation, and cytokines released such as TNF alpha and interleukin 6. Coming to the DMARD therapy in rheumatoid arthritis. So DMARDs are the cornerstone medications aimed at modifying disease progression. Classical DMARDs such as methotrexate, hydroxychloroquine, sulfasalazine, leflunomide are widely used in established safety. Biological DMARDs targeted cytokines like TNF alpha blockers, IL-6 like Antracept, adalimumab, golimumab are the other examples. JAK kinase inhibitors, another kind of DMARDs, besides tofacitinib, which interface with the intracellular signals pathway. So coming to the role of biomarkers in rheumatoid arthritis management, ESR-CRP are the acute phase reactants elevated in the inflammation. Anti-CCP and rheumatoid factors help in diagnosis and prognosis. Biomarker guides treatment adjusted and assess the therapeutic efficacy. So new markers such as calprotectin, MMPs, and soluble interleukin 6 provides the additional insights. So coming to my study now. So my study was a retrospective study with 50 patients, which were all DMARDs naive rheumatoid arthritic patients. So the inclusion criteria were diagnosed by ACR 2010 criteria with age more than 18, seropositive negative rheumatoid arthritis. The exclusion criteria were pregnancy, any undergoing surgery, or DMARD intolerance, or any cause which leads to DMARD's interruption. All those patients were excluded from the study. The interventions were methotrexate 15 mg weekly, HCQS, which was done by the weight, sulfasalazine 1 gram per day, and as per the severity. So methotrexate was the first line therapy for all the patients. HCQS was given as per the weight, that is more than 60 kgs, like we know that HCQS, the dose is 6 mg per kg. So if the patient was almost 60 kgs more, then we gave 200 PD, and if the less than 60 kgs, then we gave 300 OD. Sulfasalazine was also added, but only to the moderate and severe cases. NSAIDs like diclofenac 75 mg per day and corticosteroids like methylprednisolone with a tapered dose were used, but those were used only for the short term for the symptom control. So we prescribed diclofenac and steroids only for maximum 3 weeks, 21 days, not more than that. The mean age of the whole study population was 42 years, ranging between 41 to 50 years. The predominance was in the females, and RA positivity was also seen in almost 90% of the patient. Almost 12% of the patient had diabetes mellitus, and 6% had hypertension, and 2% had the combined comorbid condition. So these are the biomarker trend of ESR-CRP. As we can see that the ESR baseline was 32, which at the 6 month reduced to 13. Whereas CRP also at baseline it was 12, and at 6 month it was 4. Coming to the disease activity index. So the SDI score was 22 mean at the 0 interval at the baseline, which got reduced to 13 at the 6 months. And similarly, DAS28 score also was at baseline it was 5, and at the end of 6 months the DAS score was 2.2. I would also like to clear that in the study period there were 4 intervals in which the study design were assessed. That was at the baseline, at the 4 weeks. That was the first time where patient was coming after the DMARD therapy started, then after 12 weeks, and then after 6 months. The CDI score also showed the declining nature, where at 13 at the baseline and 5 at the end of 6 months. VAS score also was assessed, which got also reduced from 5 to 0.6. So coming to the discussion part, DMARD showed significant reduction in the inflammation, that is ESR-CRP, with the disease activity. VAS score reflected marked improvement in the pain levels, and short-term glucocorticoid use was controlled and did not skew any long-term outcomes. So coming to the conclusion and clinical implications, DMARD therapy is an effective in rheumatoid arthritis symptom control and disease suppression. Biomarkers like ESR, CRP, and indices like DAS28 and SDI serves as reliable monitoring tool. Early treatment leads to better outcomes, and further studies needs the longer follow-up and radiological analysis are needed. So clinical message I would like to give with my study is that early DMARD therapies improves the significant RA outcomes. Inflammatory biomarkers and clinical indices must guide the therapy decisions. Regular monitoring is essential for effective disease control, and personalized treatment strategies should be emphasized. Thank you.
Yeah, thank you so much.
So only thing is, when you are doing treatment with DMARDs,
Ji, sir.
so it takes minimum 6 weeks to
Act.
work on the
Yes, sir.
on that particular inflammation.
Yes, sir.
Okay, so meantime we have to use steroids, corticosteroids.
Yes, sir.
That is most important. Okay. Loading dose 80 milligrams of methylprednisolone or 10 milligrams of prednisolone. At least first 6 weeks you have to control with that is
Okay.
most important.
We did it for 3 weeks, sir.
Three weeks may not be sufficient,
Okay.
but usually 6 weeks, 6 to 8 weeks.
And we used
Yeah.
steroid only in the moderate disease
Yeah, yeah.
activities, sir.
Yeah. So that is the only point.
Okay, sir.
Along with the DMRs,
Yes, sir.
so you have to, how long you have to use steroids, that is most important.
Okay, sir.
Fine, thank you.
Thank you, sir.
Next one, please. Who's the next one? Who's the next one?
Sir, I am Dr. Siddharth Bansal.
Have you given your paper?
Sir, actually there was shortage of this.
Okay,
paper.
okay, no
Yes,
problem,
yeah.
no problem, no problem. So one exiting candidate finally pooped in. So yeah, please go ahead.
So good morning, everyone. My research topic was a systematic review on the guidelines for -28 score in initiating multi-drug therapy in the treatment of rheumatoid arthritis. And I did this publication under the guidance of Dr. Manish Khanna sir and Dr. Partho Das. So we'll talk. Coming to the background, -28 has emerged as a cornerstone for assessing disease activity in RA and guiding therapeutic decisions, and numerous guidelines adopted -28 as critical tool for initiating and monitoring multi-drug therapy. However, the existence of multiple guidelines raises important questions. Number one, these guidelines are based on similar research evidence. Are their recommendations regarding -28 consistent, or do substantial differences exist? Number two, why do different guidelines propose varying approaches to initiating multi-drug therapy even when based on the same disease activity score? Number three, what has been the impact of these guidelines on clinical practice, and what gaps remain, and how can future guidelines address these gaps to enhance -28 based therapeutic strategies? So the primary objectives were to assess the range and consistency of -28 based recommendations, identify variations in therapeutic targets and strategies, and to evaluate the specific drug combinations recommended for patients based on their -28 scores. By synthesizing these findings, we aim to provide insights into the value, limitations, and future directions of -28 focused guidelines in RA management. So our literature search, we searched Medline and AIM-based databases using the terms -28 rheumatoid arthritis and multi-drug therapy, and we reviewed guidelines from leading national and international organizations like NICE, ACR, EULAR, and SIGN. So our inclusion criteria were publications explicitly identified as guidelines that included -28 thresholds for initiating multi-drug therapy in rheumatoid arthritis, guidelines addressing combinations of conventional DMARDs, biologics, or targeted synthetic DMARDs, guidelines published between January 2000 and January 2023, and guidelines available in English. Exclusion criteria were guidelines focused solely on safety monitoring of therapies or specific treatment classes, and appraisals of single drug or specific technologies without broader -28 based recommendations. So screening and data extraction, we extracted data included year of publication, organizations and contributors involved, methods used for guideline development, use of systematic reviews in guidelines development, -28 thresholds and their application in initiating multi-drug therapy, therapeutic strategies and targets, and categories of drug therapies recommended. So we did quality assessment using established frameworks, and a methodological approach was using PRISMA guidelines. Methods of analysis, we concentrated on 3 predefined areas. Number 1, -28 thresholds for initiating and adjusting multi-drug therapy. Number 2, treatment targets including remission or low disease activity. And number 3, recommended drug categories including conventional DMARDs, biologics, and JAK inhibitors. So coming to the results, total 482 articles were identified, out of which 19 met the inclusion criteria. And all guidelines recommended -28 as key tool for assessing disease activity, recommended use to classify patients into high, moderate, or low disease activity states. Out of them, 15 guidelines recommended initiating multi-drug therapy in patients with moderate to high disease activity as defined by -28. Out of them, 4 guidelines also added additional clinical or patient-specific factors to initiate the multi-drug therapy. And methotrexate was commonly included as a first-line component of all multi-drug regimens. 16 guidelines recommended need for regular -28 monitoring to guide treatment adjustments, and 3 guidelines provided specific -28 thresholds for modifying or tapering the therapy. Guidelines varied on preferred combinations of conventional DMARDs, with fewer offering detailed recommendations on integrating biologics or targeted based -28 scores. So -28 in multi-drug therapy, all guidelines emphasize -28 as the central metric in assessing disease activity and guiding therapeutic decisions. In the treatment initiation, guidelines consistently recommended initiating treatment with conventional DMARDs when -28 indicated moderate to high disease activity, that is more than 3.2, and methotrexate was the first line in all regimens. And role of combination DMARD therapy, 13 guidelines explicitly addressed combination DMARD therapy, recommending its used in patients with poor prognostic factors or inadequate response to monotherapy. And commonly cited combinations included methotrexate with sulfasalazine and hydroxychloroquine, or methotrexate with leflunomide. So these were the studies that were included. All the studies were done by the rheumatologists, and the period was from 2001 to 2023. So in the biologic DMARDs were recommended in 14 guidelines as a subsequent option for patients with insufficient response to conventional DMARDs. Glucocorticoids, short-term glucocorticoid therapy was endorsed by 12 guidelines for early disease control in combination with DMARD initiation. Long-term glucocorticoid was generally discouraged due to concern about adverse effects. Non-drug interventions, 9 guidelines address the role of non-drug therapies such as physiotherapy and patient education, emphasizing their importance as adjuncts to pharmacological management. These are the recommended treatment targets and the drug target recommendations. Coming to the discussion, our systematic review of 19 guidelines suggests -28 used for regular disease monitoring, and it is key tool for assessing disease activity and used to classify patients into high, moderate, or low disease activity status. We have already discussed this. Initiating multi-drug therapy, moderate to high disease activity, that is more than 3.2, and a few guidelines also additional clinical or patient specific factors, and methotrexate at the first line. In the treatment adjustment, regular -28 monitoring is required, and specific -28 thresholds are also provided by few guidelines. but only a few guidelines offering detailed recommendations on integrating biologics or targeted therapies based on -28 scores. So use of biologics is not very much included in these studies. So the limitations in the literature were involvement of patients and multidisciplinary experts. Most of the guidelines were provided by the rheumatologists, and input from the other healthcare professionals was very less. Range of methodological approaches, that some guidelines included systematic reviews, whereas others lacked comprehensive reviews and were based primarily on expert consensus. There are differences in the precise -28 thresholds used to determine when to initiate or escalate therapy, and guidelines differ in their recommendations for combining conventional DMARDs, with some advocating for combination therapy in certain patients and others offering more cautious advice. And most of the guidelines were made a decade ago, and consequently some of them recommendations may be outdated, and future updates will need to account for the latest evidence. So coming to the conclusion, key recommendations in guidelines is -28 is central tool in assessing RA progression and guiding therapeutic decisions. Early initiation of DMARDs is recommended. Methotrexate is first line. -28 is a measure for classifying disease activity into high, moderate, and low. -28 guides the initiation of multi-drug therapy and also adjustment of therapy. Specific -28 thresholds for adjusting or tapering treatment, and there is significant role in determining eligibility for biologic treatments. So these are the references. Thank you.
So in multi-drug therapy, so method you want to start leflunomide. So prerequisites. What are the for whom to give leflunomide? That is most important. That is everyone should know about that. So only it is reserved for after family planning.
Yes.
Persons
Should not
only.
be given in
Yeah,
young
yeah,
females.
yeah, exactly.
Yes.
During fertile time period, it should not be given. It causes teratogenicity not only during pregnancy, before pregnancy, even after. If stopping the drug at least for 4-5 years, we have to wait. That is most important. So that's why. So even this tofacitinib also causes teratogenicity. So that's why. So you have to be when you give multi-drug therapy, you have to be cautious about all these side effects and contraindications and all these things. Okay, thank you.
So nice, very nice. I'll ask to all the exiting people, every time whenever you see a patient, it is always possible to have a DAS scoring very sensitive to diagnose a patient. Is it like theoretically, yes, it should be there, like, but many time it is an undifferentiated early type where you have to develop your inner sense and to start a DMRD, maybe a methotrexate or maybe a sulfasalazine. Any comment on that? Because now you are also orthorheumatologist in that way. Any comment on that? What I want to say is we have to always not depend on DAS scoring. Sometime there are some borderline cases where we are not able to pick it up as a positive, as a case of a rheumatoid, but they may be a early undifferentiated features where we should start sulfasalazine or hydroxychloroquine, for example, in a reactive arthritis or post chikungunya. You're not going to find everything in a positive way, right? Yeah, thank you so much.
My question is another question. Why there is a limitation of using DAS score in orthobiologics? You have excluded, I think, in your study. He has mentioned that he has excluded these orthobiologics from this DAS study. So what is the reason? When I want to know.
Yeah, anything which you want to say on this? You're not able to get it.
Orthobiologics.
you have in your slide that you have mentioned there is a limitation of study is the orthobiologics in dash score. So what is the cause?
So maybe you are trying to use some stem cell or some regenerative.
There lots of work is there, so this could change this dash score.
You just go through it. Yeah, you just go through it and come on,
Okay.
come to us. Thank you.
Thank you, Siddharth. Thank you, sir. Now we move on to our inaugural functions. All our dignitaries have arrived. So I would like to welcome Dr. Manish Khanna, sir, and will request him to welcome our guest. Manish Khanna, sir. First of all, I would like to invite Dr. P.L. Srinivas, sir. He is professor and head of the department, Osmania Medical College and Hospital, Hyderabad. Member of Feiora and ISCGS Life, practicing orthopedic and orthorheumatologist since 30 years, mainly dealing with osteoarthritis, polyarthralgia, cervical and lumbar discogenic pain, regularly giving lumbar and cervical epidurals. So far, he has given 7,000 lumbar and 300 cervical epidurals and have given excellent results. Well, we welcome you, sir. Now, I would like to call upon Dr. Partha Sarthi Sarkar, sir. He is professor and head of the department Orthopedic North Bengal Medical College and Hospital. He is immediate past secretary of West Bengal Orthopedic Association, Secretary General of Indian Orthopedic and Rheumatology Association, and EC member from West Bengal in Indian Orthopedic Association. He is specialist in spine surgeries. We welcome you, sir. Now I would like to call upon Dr. M.D. Kumar, sir, who is an orthopedic surgeon, head of the department in ESIC Medical College and Hospital, Chennai. He has got an experience of 28 years and more than 2 decades of contribution to the field of trauma, arthroplasty, and orthopedic oncology. His focus is mainly in the surgical management of musculoskeletal tumors, limb salvage surgery, sarcoma care, and complex reconstruction. We welcome you, sir. And I would like to welcome Dr. Pandey, sir. We will be getting lot of insight from him in terms of legal aspect. Pandey, sir, he has been always there to guide us, and you will be deeply benefit from not in medically but in legal aspects. Pandey, sir. Sir, thank you very much for your insights. Now I would like to hand over the mic to Dr. Manish Khanna, sir.
Good morning, everyone. So we are back here after a year, and this is the, I think, sixth batch. So 7th year would be in the starting phase. So we'll start with the Saraswati.
Now, I would like to welcome all our dignitaries for lighting the lamp and officially beginning the exit exam and entry exam event. Please, sir. Please, sir. Join. Srinivas.
So we are actually a little bit late today in starting the program. So I'll just wind off very fastly what is about the journey of the Feiora. So this is a continuous academic learning module, Feiora. It's a pride of orthopedic rheumatology, pride of stem cell, pride of the law fraternity. And here you are actually. Now this fellowship was being started as a self-directed learning tool for all of us during the COVID time, at which time we were just trying to bring out the textbook of orthopedic rheumatology, which is already been there in the market. It is covering all the subject of orthorheumatology. And gradually we found that orthobiologics, which is very useful in orthorheumatological practice, like in osteoarthritis and rheumatoid arthritis. So we club up the regenerative part of the orthopedic, that is orthobiologic, in this fellowship program. Indian Orthopedic Rheumatology Association has a index journal, which we are always trying to push it up, and we are trying to every year to motivate our fellows to submit their publications if they are not been accepted at anywhere, but every time it has been accepted all the places. And this is how during the COVID time the things started rolling, and we started with the micro online discussion at that time, and gradually the fellowship program was being started in 2020 here in the university. This is the previous VC. He's been there for the last 3 years. Now VC has been changed. Sir is busy. Dr. Singh sir is busy. He is in Raipur. He wanted to join here in this meeting, but I am trying to catch him up on the WhatsApp also and on the mail. But since his flight has been landed late, most probably, so he's not able to join it. So this was the first batch, which was being inducted and gradually cleared. 100% result was in the first batch in 2020. Then this was the second batch, and so on. Every year we are meeting here with the cause of orthopedic rheumatology and stem cell with the exit event. So this is a workup of what we have done in the last 5-6 years. This is the exit event, and we have always it is a pride of Feiora to have our synopsis work done, and few of the good synopsis has been placed near to the external examiners just as a role model that what they have done it, and that is a very good form of expressing the interest in orthopedic rheumatology altogether. So this was the last year batch, and then this was the 5th batch. So I think all these slides are boring for everybody. So, but this for the record, this is our VC sir, Professor AP Singh sir, and he is not available today. So we'll miss him. And this is the cake cutting ceremony of the last year batch. So the torch of the Feiora fame is moving ahead each and every time. And we appreciate that all these exiting fellows, after getting this Feiora fellowship, if they are able to do it in the first way, I feel they all get it with all my best wishes, that the science of orthopedic rheumatology or the stem cell is in a very, very nascent initial stage. So it is our duty to learn as a student and to grow it to a level where it should be, at a cloud 9. Thank you so much. And now we can stand for a national anthem, and then we can move further for the rest of the program.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
Thank you very much, sir. Now, I would like to call upon Dr. Vinay Vijay for his presentation. Please make your presentation precise and short. Okay? Thank you. Good morning, sir. My topic is effect of increased uric acid level in inflammatory arthritis and spondyloarthropathy. Spondyloarthropathies, an overview. So, spondyloarthropathies are a cluster of interconnected inflammatory conditions, including ankylosing spondylosis, reactive arthritis, psoriatic arthritis, spondyloarthropathy linked to inflammatory bowel disease, and undifferentiated spondyloarthropathy. These share a genetic basis with the HLA-B27 gene and are fundamentally defined by enthesitis, the inflammation where tendons or ligaments attach to the bone. Clinical presentation and diagnosis. Clinically, these diseases often manifest with inflammatory back pain, dactylitis, and various extra articular symptoms such as uveitis and skin rashes. Diagnosis primarily involves a thorough medical history and physical examination. Radiographic evidence of sacroiliitis inflammation of the SI joint provides the significant diagnostic support. Clinical presentation often present with inflammatory back pain, dactylitis, extra-articular symptoms like uveitis, skin rashes, and history and physical examination. Sacroiliitis on the X-ray supports the diagnosis. Treatment and distinction from rheumatoid arthritis. Treatment typically involves NSAIDs, sulfasalazine, methotrexate, TNF alpha inhibitors. Early diagnosis and timely appropriate treatment are the critical to minimize the risk of long-term disability. Unlike rheumatoid arthritis, where synovitis is the primary joint abnormality, spondyloarthropathy involve not only synovitis but also spinal inflammation, dactylitis, and enthesitis. Synovitis in spondyloarthropathy is considered distinct from the rheumatoid arthritis, although histologically similar with enthesitis, playing a more significant role in spinal involvement. Most non-rheumatoid inflammatory arthropathies shows more similarities to spondyloarthropathies than the rheumatoid arthritis. Treatment and distinction from the rheumatoid arthritis. Treatment includes NSAID, sulfasalazine. Early treatment is and crucial. RA is the main issue is that synovitis. Spondyloarthropathy involves synovitis, spondylitis, and dactylitis. Joint inflammation and enthesitis in spondyloarthropathy. Spondyloarthropathy joint inflammation is unclear. Subclinical synovitis infection suggested but unproven. enthesitis, key synovitis is also unclear. Role of cytokines and potential origin of synovial components. Synovium sensitive to pro-inflammatory cytokines, interleukin 1 or TNF alpha. Uric acid and its pro-inflammatory effect. Uric acid includes MTP1 joint, activates NF-P35 marker. Uric acid levels in rheumatic diseases and their current study focus. Serum uric acid study in rheumatoid arthritis, SLA, psoriatic arthritis. Significance of studying uric acid in inflammatory arthritis and spondyloarthritis. High uric acid worsens the joint inflammation and disease. Understanding this improves the treatment. Advancing knowledge of metabolic factors in inflammatory diseases and aims to find relation between serum uric acid and spondyloarthropathy. Methods. This is a 6-month cross-sectional study included 100 diagnosed arthritis patient whose age is from 18 to 65 years from an orthopedic OPD. Participants had inflammatory arthritis or spondyloarthropathy confirmed. Exclusion criteria involve conditions of medication affecting uric acid or disease activity. Data descriptive statistics were used to summarize the characteristic of study participant, association between uric acid level and disease activity score. This is the mean age is 52 plus or minus 12 years. Males are 56%, females are 32%. Serum uric acid 8.5 plus or minus 4. Limitations of the study. The small sample size may limit the generalized of finding, as the retrospective study potential unmeasured medications might influence the relationship between uric acid and disease activity. Conclusion. This study found a significant positive correlation between serum uric acid levels in the disease activity in the both inflammatory arthritis and spondyloarthropathy group. Elevated serum uric acid independently predicted higher disease activity even after adjusting for age and disease duration. Higher serum uric acid levels were observed in the patient with greater disease activity in both conditions, suggesting a strong link. Further research is needed to understand the underlying mechanism of this association and its clinical implication for managing these conditions. Clinical significance. Elevated uric acid may worsen joint inflammation and disease progression. Recognizing this could lead better treatment strategies focused on managing uric acid levels, potentially improving symptoms and quality of life for the patients with these conditions. Thank you.
Several other factors also influence the uric acid to increase, like age, gender, diet.
Yes. But as like ESR CRP, uric acid level increased also suggestive of there is uncontrolled disease activity.
Diet is also important.
Yes,
Okay.
sir.
So what diet he is taking? So that's why whenever the patient comes to us, so we advise not to eat this type of food.
Purine foods.
Yeah, especially.
Hmm.
So that yeah. So that's what. So you have to advise those.
Yes, sir.
Mhm. So whenever this serum uric acid levels are increased with other associated conditions, so we don't know what is the cause. Okay.
Yes.
So that's why you have to advise not to eat other foods,
Yes.
purine, high purine diets.
Yes.
Okay.
What is the duration of the drug? should you prescribe a drug and if you prescribe the drug, then the duration of the drug, what drug will you prescribe?
Firstly, I will advise dietary modification only, sir. And urate lowering therapy like febuxostat if needed, if uric acid is more.
In acute condition, febuxostat is working or?
No, sir. Colchicine is the drug of choice.
Yes. But if you start this drug, this should be for the lifetime. I think this is the now recommendation.
Thank you very much, sir. I would like to welcome Dr. Kronal for his presentation.
Thank you everyone. I am presenting my publication that is Diagnosis and Outcome of Antenatal Osteogenesis Imperfecta, a global meta-analysis done under the guidance of Dr. Manish Khanna and Dr. Vishnu Senthil, sir. Osteogenesis imperfecta is a group of rare genetic disorder with brittle bones, and its severity ranges from a neonatal death to the mild symptoms. And out of types, the type 2I is the most severe and often lethal. The importance of prenatal diagnosis is aid in the parental decision making and also assist in the further management assist in delivery and neonatal planning and counseling of the parents for further recurrence risk. The objective of study was to assess the USG accuracy in prenatal OI diagnosis and evaluate its impact on pregnancy outcome. The systematic review was done under the PRISMA guidelines, and the databases that are searched are PubMed, Cochrane Library, and Google Scholar. And after the primary screening, total 11 articles are included, and with 106 number of cases. The commonly applied diagnostic criteria on USG in these articles are shortened and bowed long bones, hypomineralized bones, multiple fractures with beaded ribs, poor Calvarian ossification, chest hypoplasia, and oligohydramnios. Risk of bias assessment done using the Robbins 2 tool, and the 7 domains are assessed for bias, and most studies have low risk of bias. The results, a total 106 cases, USG diagnosed 83 cases correctly, that is 78%. And 84 cases have studies have mentioned outcomes of 84 cases, which include termination or in 50 cases, perinatal mortality in 15 cases, and live birth in 19 cases, out of which 3 were done via cesarean section. Additional investigation employed in some studies are include amniocentesis, 3D CT in 2 studies, and trio exome sequencing in 1 study. The key finding of the this research this article was second trimester USG is the most effective tool, and it is one of the most accessible and non-invasive modality of investigation. 3D CT and genetic tests are more accurate, but they are not accessible to all the population. Discussion, obstetric ultrasound has become a standard component of antenatal care, and diagnosis influence both ethical and clinical decision making. First trimester diagnosis is limited, and experience of sonographer is also a critical part in the USG diagnosis, and 3D USG is preferred over the older 2D USG. Limitations of USG include that availability of skilled sonographer is most important thing to be noted, and subjective in nature. Additionally, the measurement of parameters in early stages require experience to obtain the best scan to visualize bone segments, which measures just a few millimeters. This limits the early diagnosis in first trimester difficult. Thus, the ultrasound examination at 18 to 22 weeks is a mandatory. The conclusion of this study is the second trimester USG is the investigation of choice, and the diagnosis impacts both parental decision making and outcome. Also to counsel the parents regarding termination of pregnancy and the recurrence of the disease in further future pregnancies. And the triad of shortened bones, fractured, and hypomineralization are the most consistent findings in the USG. Key references are mentioned. Thank you.
How this study will help this disease? What is the, tell me.
First, uh, uh, help in making the guidelines of diagnosis OI, which were very different in different articles. So it make a generalized common guideline to sonography findings to establish the OI diagnosis, and candidates to require further any investigations like amniocentesis and genetic testing at the higher centers. So in periphery and remote setting, this will improve the screening.
Can you find the severity of the osteogenesis imperfecta in USG?
Yes, sir. These findings are mainly seen with type 2, which is the most severe and lethal form of osteogenesis imperfecta. So it helps to diagnose the OI type 2 correctly in prenatal phase only. And by this we can make the early decision of termination of pregnancy, which was limited till 28 weeks in Indian Constitution. So we can counsel the patient or parent regarding the same, and also counsel them for risk of future pregnancy, and decrease the mental and emotional burden of the parents by early diagnosis. Thank you, sir.
Now I would like to call Dr. Kanav Mahajan for his presentation.
Good morning, everyone. I'm Dr. Kanav Mahajan from Jammu. My study was conducted under the guidance of Dr. Vishnu and Dr. Manish Khanna. So topic is comparative study to assess the effectiveness of methotrexate and tofacitinib in patients diagnosed with rheumatoid arthritis. A little bit of introduction about the disease. Rheumatoid arthritis is a chronic inflammatory arthritis characterized by the inflammation of the synovial lining of the joints, tendons, and periarticular structures, with main features of joint inflammation, swelling, and joint destruction. There are many pharmacological and non-pharmacological therapies such as patient education, psychological interventions, weight control, and enough rest. All are necessary in the management program. The first line of therapy for rheumatoid arthritis is methotrexate, also known as disease-modifying anti-rheumatic drug. Methotrexate inhibits cell growth by interfering with the dihydrofolate reductase, and its uses are in choriocarcinoma, abortion, non-Hodgkin lymphoma, Crohn's disease, ectopic pregnancy, and rheumatoid arthritis. The adverse effect which you have to look in while using methotrexate is myelosuppression, mucositis, and hepatotoxicity. The other drug is the tofacitinib, which we have used in our study, is the JAK kinase inhibitor. It acts by blocking the action of JAK enzyme. The clinical uses of tofacitinib are in rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, juvenile idiopathic arthritis, and ulcerative colitis. And its adverse effect are in the death of patient also. Material and methods. The present study was conducted in the orthopedics OPD of ESIC Model Hospital, Badi Brahmana, Jammu. On an average, we see 80 to 100 patients. Study design is a prospective hospital-based study. The period is from 1st May 2024 to 31st December 2024. Study population. The population consists of patients of rheumatoid arthritis aged between 20 years and above attending orthopedics OPD. Inclusion criteria was subjects willing to give consent, age 20 years and above. Subjects of both the gender were included in the study. Subjects diagnosed with rheumatoid arthritis and prescribed either methotrexate or tofacitinib. Exclusion criteria was individuals not willing to provide information and pregnant and lactating women. Ethical consultation was taken from the hospital committee. Sampling technique was convenient sampling method. Data collection was through each eligible and willing participant were explained the purpose of the study. Thereafter, written informed consent was taken from the participants and interview was conducted in accordance with the pre-designed semi-structured study performer. These are the scores which we have used in the study. This is the SDI score, which includes how many joints are tender, how many joints are swollen, and the CRP count. Pre-starting the count from pre-starting the medication and after starting the medications. This is the DAS calculator along with the ESR and the CRP, DAS 28 with ESR and DAS 28 with CRP. And this is the EULAR criteria which we use in our study. A total of 100 patients diagnosed with rheumatoid arthritis were enrolled in the study, out of which 50 patients were put on methotrexate 7.5 milligram weekly, and other 50 were put on 5 milligram BD tofacitinib. This is the gender-wise distribution given in the pie charts. The age-wise distribution given in the two study groups. And this is the comparison of CRP between tofacitinib and methotrexate group, depending upon the start of the treatment, that is the 0, and the second month and at the 5 month. And we can see the tofacitinib group has given more improvement. And this is the comparison of ESR in both the groups. In this also, we can see that tofacitinib has given a better results at 0, 2 and 5th month. The conclusion of the study is that study aimed to compare the effectiveness of methotrexate and tofacitinib in patients with rheumatoid arthritis. The result indicated that tofacitinib is more effective than methotrexate in managing rheumatoid arthritis with high disease activity. All the patients which we included in the study were the high disease activity patients. Thank you.
Did you combine methotrexate with the tofacitinib?
So we have some patients of that also, but we have not that included in the study. In this study, we have taken only tofacitinib separately and methotrexate separately. Okay. Those patients which you are talking, they have given more better results than this also.
Did you check the remission rate for both the drugs?
So study period is, time is very less to see. We are seeing that, we are following that study so that we can give the remission in future for a better prolonged study. It was only a time period of 8 months, so we could not see much about remission and relapses.
You have measured both the scores for the each and every patient.
Yes, each and every patient we have made a performer.
So how much time it will take to measure this for the each patient?
So we used to write because it's a computer based. Now we used to write the IP number of the patient.
Okay.
And whenever we were free, so we used to we had the performer and the scores. We have downloaded calculators on our mobile. So whenever we had a free time, we used to do 5 patients, 10 patients, whatever was coming in the OPD.
Wow, very good.
In severe cases, you only give 7.5 milligram, or you exclude it?
No. So this study, we designed it for study only. 7.5. We have 15 we are using 15 milligram also. We are using combined also. We are using triple drug therapy. Those patients are separate. These patients were dedicated for my study only, and all the patients were seen by me only. Because it was told to every colleague that I am doing a study. So they were all those patients who were on this therapy, either methotrexate or tofacitinib, they were sent to me by them just to make study, because I won't find so much patients in short span of 6 months, new patients. No, 5 mg BD, not 11 milligram OD, 5 mg BD. Every patient was, because that is the only available in hospital. It's a ESI hospital, free of cost is available. So we have to give patients everything which is free. Otherwise, they won't come for follow-up. Thank you, sir.
Thank you very much. Now I would call upon Dr. Muthu for his presentation.
Good morning, everyone. Mine is a scoping review on the implications of gut microbiome in the fibromyalgia. It was done under the guidance of Manish Khanna sir and Madan Jayaraman sir. So as we all know, fibromyalgia is a chronic pain syndrome with a musculoskeletal pain, fatigue, sleep disturbances, and cognitive dysfunction. So it's commonly referred as fibro fog, which impacts significantly the quality of life. So what's the need of this paper? Despite extensive research, no single etiology has been identified till now for a complex multifactorial origin. Mainly the theory says that genetic predisposition, environmental triggers, central and peripheral nervous system alterations, and immune dysfunction. So what is the recent scenario at present is there is an emerging evidence suggests that a gut microbiome plays a critical role in modulating various biological processes, including the pain perception, immune function, and neuroinflammation, all of which is implicated in fibromyalgia pathogenesis. The alterations in the gut microbial composition leading to dysbiosis is a main cause for the fibromyalgia as a recent theory. There's a gut-brain axis, which is a bidirectional communication network between the gastrointestinal tract and the central nervous system, which is a key player in chronic pain conditions. So aim of this study was to explore the potential implications of gut dysbiosis in fibromyalgia, particular focus on its new pathomechanism. Key areas of interest include the microbial alterations, immune interactions, intestinal permeability changes, neurochemical pathways which link to the fibromyalgia symptoms. This review seeks to provide a comprehensive understanding of gut microbiome's role in fibromyalgia, potentially unveiling a novel insights into disease etiology and progression. It helps the future research directions to establish biomarkers and therapeutic strategies for the fibromyalgia. So we used a systemic search on electronic databases, including the PubMed, Scopus, and Web of Science, to identify the articles published in the last 2 decades. Search strategy was designed to encompass a comprehensive range of studies exploring the relationship between gut microbiome and fibromyalgia. Keywords used were fibromyalgia, gut microbiome, microbial dysbiosis, immune modulation, intestinal permeability, neurotransmitter alterations, gut-brain axis. We included the original research articles and systemic reviews, meta-analysis, studies utilizing animal models or human cohorts on the gut dysbiosis, immune inflammatory markers were included, whereas the studies primarily focused only on treatment modalities and the case reports, conference abstracts was excluded. Main pathomechanism according to this study was gut microbiome alterations and gut-brain axis and neurochemical alterations. This includes the microbial dysbiosis and intestinal barrier dysfunction and immune activation. Mainly the decreased levels of butyrate producing bacteria, which is very essential for maintaining an intestinal barrier integrity, which in turn reduces the oxidative stress and modulating the systemic inflammation. Whenever there is a reduction in this bacteria, which is very beneficial to our immune system, may contribute to the increased intestinal permeability, allowing the bacterial endotoxins to enter the circulation and immune responses. There is an increased abundance of pro-inflammatory bacteria, which are producing the endotoxins like liposaccharides, which activates the toll-like receptors. In turn, it activates the immune cells, resulting in a fibromyalgia symptoms. There is an altered microbial diversity and metabolic function, which shifts the firmicutes to bacterioids ratio, which has been associated with metabolic dysfunction and immune dysregulation. These changes may disrupt the production of key microbial metabolites such as short-chain fatty acids, neurotransmitters, and bioactive components involved in pain modulators. So there is a potential involvement of gut-derived neurotoxins, which helps in the influencing the central sensitization in fibromyalgia patients in gut-brain axis. So dysbiosis related disruptions in tryptophan mechanism and serotonin synthesis could contribute to the mood disturbances and pain hypersensitivity in the fibromyalgia patients. Coming into the intestinal barrier dysfunction and immune activation, this role is mainly played by the good gut microbiota. Dysbiosis can compromise this barrier function, leads to a condition called leaky gut, allows a translocation of bacterial endotoxins such as liposaccharides into systemic circulation, initiating an immune activation and inflammatory cascades. There is a systemic immune activation via liposaccharide, triggering the release of pro-inflammatory mediators. This sustained immune response may contribute to the pain sensitivity and fatigue, which is commonly seen in fibromyalgia. There is an elevated level of pro-inflammatory cytokines like TNF-alpha, IL-6, IL-1, and IL-1 beta, which correlates with pain, hypersensitivity, neuroinflammation, and central sensitization. There is a disruption of tight junct proteins such as zonulooccludins, which regulate the epithelial barrier integrity. Whenever there is a compromised gut barrier, leads to an influx of microbial antigens, exaggerating the immune dysregulation and systemic inflammation. There is a microglial activation in the central nervous system, which relates to the neuroimmune crosstalk, enhancing the pain processing and contributing to the cognitive dysfunction. Whenever there is a gut-brain axis dysfunction, there are release of neurochemical alterations in our body, releasing the neurotransmitter synthesis, metabolism, modulating pain perception, mood, and cognitive function. The gut dysbiosis has been linked with the disruptions in key neurochemical pathways, contributing to central sensitization, widespread pain. There is a serotonin deficiency. Approximately 90% of the fibromyalgia serotonin synthesis in gut, where there is a microbial metabolites influencing its production, Reduce in the level of gut-derived serotonin may contribute to the mood disorders, sleep disturbances, and heightened pain sensitivity. Alterations in tryptophan metabolism, a serotonin precursor, may further exacerbate a neurotransmitter imbalance. So GABA and glutamate imbalance also causes hyperalgesia, anxiety, and impaired pain modulation. So this is one of the reason we are giving anti-GABAergic drugs in the fibromyalgia patients. There is a neuroactive short-chain fatty acids which modulate the neuroinflammation, glial cell activation, and blood barrier integrity. Reducing the levels of the short-chain fatty acids may contribute to the neuroinflammation and altered pain processing in fibromyalgia patients. There is a dysregulation of gut-brain axis. The vagus nerve serves as a critical communication pathway between the gut and the brain. Whenever there is an altered microbial composition and metabolic production, disturbs the vagal signaling, further contributing to the autonomic dysfunction, mood disturbances, and pain hypersensitivity. So the microbial metabolics include the short-chain fatty acids, tryptophan derivatives, bile acids play essential role in neuroimmune modulators and hemostasis. So whenever there is an increased myoglial activation and neuroinflammation, there is a dysregulation of hypothalamic pituitary adrenal axis functions, altered tryptophan metabolism, and a bile acid imbalance and neuroimmune crosstalk. So this is a flowchart describing the gut dysbiosis leading to fibromyalgia. Whenever there is a leaky gut, it results in the systemic inflammation, giving a neuroinflammation and myoglial activation, central sensitization, fibromyalgia symptoms, and the cycle continues with this. Inflammation and neurotransmitter imbalance in fibromyalgia. Again, it starts with gut dysbiosis, increased production of the liposaccharides, leaky gut, chronic immune pro-inflammatory cytokines, the CNS inflammation, altered neurotransmitter levels with a decreased serotonin and increased glutamate. So there is an increased pain sensitivity and fatigue, resulting in fibromyalgia-like symptoms. Conclusion, these findings suggest that the gut microbiome alterations play a key and pivotal role in neurotransmitter dysregulation and central sensitization in fibromyalgia. This underscores the significance of microbial metabolites in the pathophysiology, highlighting the potential mechanisms linking the gut dysbiosis, neuroinflammation, and systemic dysregulation. The interplay between the microbial alterations, systemic inflammation, and the neurotransmitter inflammation suggests a complex disease which warrants further exploration. Limitations of this review is it does not address the treatment implications. Understanding this pathophysiological process lays a critical foundation for future research in diagnostic and preventive strategies. Identifying a microbiome-based biomarkers may aid in the early detection of the risk assessment, while further studies are needed to establish a causal relationship between the gut dysbiosis and the fibromyalgia symptoms. Expanding our knowledge of gut microbial contributions would potentially pave way for novel therapeutic approaches, improving the disease management and patient outcomes. These are my key references.
Can you please specify the gut microbes that help the treatment of this?
So like previously they were using like prebiotics and probiotics, like Faecobacterium and Butyrus, and producing the...
These probiotics?
Yes, so probiotics and prebiotics.
Was there any diagnostic tool in any of the papers to find the...
No, sir, we didn't include the diagnostic tool papers or treatment papers were excluded from this. We are mainly focusing on the pathophysiology, what recent articles suggested in last 2 decades. Sir. So that we can focus only on what is the pathomechanism involved in this. Then we can go for further future warrants, biomarkers, related biomarkers, and the treatment modalities. Thank you.
Thank you very much. Now we will be having a short tea break, and after 15 minutes, we will assemble here for guest lectures. Thank you.
Dr. Hardik Kharbanda, where are you? Dr. Hardik. Yeah, you can go now. After Dr. Hardik, the next would be Dr. Arjit will go for the Viva on that side. And we'll start the lectures here. We'll request Dr. Pandey, sir. Rest of you all, please be seated. For case discussion, Dr. Hardik Kharbanda has gone there. Next, Dr. Arjit will go. Dr. Siddharth Bansal, you can go for your synopsis. Dr. Siddharth, you can go in that room for your synopsis table. Okay. So we'll request Dr. Pandey, sir, for the very important, interesting lecture. Over to Pandey, sir.
Thank you, Professor Khanna. And it has always been a pleasure being part of this very prestigious, now very well established and recognized fellowship program for orthopedic surgeons. Every year when I stand amongst surgeons, very young, enthusiastic, and their examiners as well, who are very seasoned professionals, globally recognized and all, I keep telling that except that doctor, which we both use in our name, there's nothing common, and I'm the only odd man out. So it's legal regulation of medical ethics that I'm supposed to speak for 10-15 minutes. I remember that on previous occasions, and that is something which often generates a great deal of interest amongst medical professionals. I've been talking to medical professionals, not only here, but also in certain other training institutions in Lucknow and beyond, on varied issues that concern, legal issues that concern medical professionals. But I've always found that when it's about those who are working with the government sector, or rather public sector, the interest lies somewhere else. Those who are working in private sector, their interest lies somewhere else. But the common interest of the community is in medical ethics. Probably in your MBBS days, you must have been taught a little bit of medical ethics. I also believe that you didn't listen to your professor then. Agree? As far as medical ethics is concerned. But then, as a professional, you must revisit, rather, you must recall those discussions that you must have had in your MBBS days, because ethics and their legal regulation is something that you must be very thorough with in your professional journey. So these are moral principles. We often believe that ethics are moral principles which guide your profession. These are important because they protect patients' rights and also seek to ensure fair medical practices, and its legal regulation is required because that legal regulation would prevent malpractices and would also ensure accountability. But we often confuse between morality and ethics, and we often use the two as synonymous. Here, I would like to draw some kind of distinction between two. I would also be using a few illustrations, and then bang on, I'll be talking about its legal regulation. So morality is personal. In fact, though that's something which is purely legal, rather part of legal history, the earliest penal law that was made, rather the process that began in 1834 by the Britishers. One question that was put to the chief architect of that particular law was that whether a doctor would be liable if he refuses to attend to a patient despite having time, despite having opportunity. Can this be regulated by law by imposing some kind of liability? The answer that was given and the position that remained was no. A doctor is not liable for refusing unless and until there is a duty to attend. And that duty is not moral duty. That duty is legal duty. In absence of any legal duty to attend, that legal duty may arise from contract, that legal duty may arise from service condition, that legal duty may arise in certain other circumstance, but if it's purely moral duty, certainly no doctor can be held accountable in the court of law. Legally, you are not responsible, even if your not attending that patient leads to the worst result, even death. That is not legally enforceable duty that you owe. So morality refers to individual principles of right and wrong. You decide. A few doctors may decide. I'm reminded of those who have little interest in literature. They may recall one story. Prem Chand, you must have heard. Prem Chand की एक कहानी है. The story is मंत्र. मंत्र में एक स्नेक चार्मर है who claims, though that's a sham claim that he can cure people who are bitten by snake and all. और एक डॉक्टर है who is professionally qualified. ये स्नेक चार्मर का बेटा बीमार है. He goes to the doctor. Doctor is about to go for his golf wala sports, and he refuses. No liability, even if the child died. No liability. Ethical liability. A doctor might have decided that nahi, aaj golf khelne nahi jayenge, and let's go and save the life of the child. But that's very individual. That's very individual. Law is not concerned with that. You are concerned with that, your inner conscience. If it allows you to go and play golf, ignoring a dying patient to whom you don't owe any legal duty, the law would not ask, why did you go? The law is not going to ask. But you have to be sure that there is no legal duty. On the other hand, ethics is a formal system of rules that guide behavior within a group of or society. That's why it's not morality of the doctors, rather ethics that each and every member of your community must comply with. There can't be any moral guidelines for doctors. Ethical guidelines for doctors are there, and those ethical guidelines are enforceable in the court of law. What may be the consequences would not be that you would have a sleepless night because you did not attend to a patient to whom you had no legal obligation to attend to, rather that you would be accountable in the eye of law. Again, morality is subjective, ethics is structured. Personal morals can vary based on beliefs and values. Personal morals. Whereas ethics is often codified in laws. Those ethical norms are codified in law. Professional guidelines are there. Societal norms are also there. But unless and until they are codified in law, there is no question of their enforcement, or there is no question of you being liable for any ethical violation unless and until that ethical value or ethical consideration has been embodied in some written law. Then again, morality is internal, ethics is external. Morality comes from one's conscience. This is something which I already told you. So take the first point. Personal versus professional. Morality is personal. Ethics is professional. One example could be that a doctor personally believes euthanasia is wrong based on their religious views. Euthanasia. Ethics. The medical community has guidelines that permit euthanasia under strict conditions in some countries. Many countries in Europe, you are aware probably, many countries are famous for what they call euthanasia tourism, where doctors are permitted to switch off the ventilator in case of a hopeless situation, or where the person on ventilator himself, directly or through his legal heir or agent, signifies that no treatment required anymore. Morality is subjective. Ethics would have objective rules. An individual chooses not to lie to their friend because they value honesty. Concerns only morality. Ethics, a lawyer must uphold professional integrity by not misrepresenting facts in court, regardless of personal feelings and all. Internal is what morality is, external is what ethics is. A person feels guilty about eating meat, for example, stops due to personal beliefs. Ethics requires all food businesses to signify that whether it is vegetarian or whether it is non-vegetarian, that is something which is regulated by law and is not a subject matter of a personal choice and all. So the codified ethics for medical professionals would be found in this 2002 document. Probably you have heard about it. It's a voluminous, very heavy kind of document. Was created by MCI, which has now been replaced by National Medical Commission. Key provisions include doctors must maintain patient confidentiality. Patient confidentiality is to be maintained by doctors. Now, in that regard, I would be talking about, I'll take 2 minutes to discuss a very interesting case that went to the Supreme Court. In 1998, that was decided, and is titled X versus Hospital Z. The facts are that this person X, that's not his real name. The court chose to maintain his confidentiality and privacy by not mentioning his name in the judgment, which is a public document. He sued for compensation this Hospital Z for divulging his HIV status to his would-be bride. उसकी फियांसी को हॉस्पिटल ने बता दिया कि ये एक्स जो है वो HIV पॉजिटिव है. This is, and he said that this was in breach of my right to privacy. This was in breach of the confidentiality which the doctors must maintain, and is also in breach of medical ethics and all. Do you know what the Supreme Court said and what led to the codification of those 2002 guidelines? The Supreme Court said that the rule is that the doctors must maintain utmost confidentiality, no doubt. But when maintaining that confidentiality conflicts with larger public interest, the doctor must divulge that particular status. Now, there are two conflicting rights at stake. One is right to privacy of this man X. But then there is another right at stake, that is right to health of that woman whom he would have eventually married. So the Supreme Court said that the hospital and the doctors or the caregivers who chose to divulge, they have not done anything unethical or contrary to that medical practice. So maintain confidentiality. Breach of confidentiality may lead to legal repercussions, but then you have to evaluate the situation that whether divulging it is in larger public interest or not. And once you do that evaluation, certainly you would be sticking to the ethical practices. Prescription guidelines are there, generic names preferred, ethical responsibilities, no false certification, I need not. Consequences of violation, warnings, suspensions, cancellations of license, this and that. Then this couple of rather 3-4 legislations which also prescribe certain ethical guidelines which have been codified into law, and breach of those ethical guidelines would lead to legal liability. So Drugs and Cosmetics Act is 1940 legislation passed by Britishers, of course. So it regulates import, manufacture, sale of drugs, cosmetics, prevents misbranded, adulterated or spurious drugs. Ethical concerns are transparent prescriptions should be there, drug safety, fair pricing. And then I'm sorry, this This is a typo. This is a 2019 legislation. Consumer Protection Act of 2019. Patients are recognized as consumers, can take legal recourse. Hospitals and doctors may be required to pay compensation for medical negligence. But what I keep telling, this is something which I was discussing on the sidelines with the exiting batch as well, that the thumb rule is that you are not supposed to be the best in your profession. The thumb rule is that whether you have exhibited the ordinary skills which anyone with the same qualification and with the same level of training would have easily exhibited. So if you have done that, even if what you did led to unfortunately some grave consequences, because you are not God, of course, you can't guarantee that every medical procedure would certainly lead to a certain positive result in every case and all. You would not be liable. What I keep telling is that the practice has been, and the law would not be in a position to check that practice, is to harass medical professionals by filing these cases. You'll be fighting those cases even if you eventually win that, and mere fighting those cases would be enough harassment and all. Then this is this Transplantation of Human Organs and Tissues Act of 1994. Ethical organ donation regulations have been given there. Consent is required, no forced or illegal donations. Consent is not merely asking one that do you agree, unless and until you tell who has agreed the pros and cons, meaning that by consent means informed consent. Unless and until it is an informed consent, certainly that would not be construed as a consent, even if you produce a paper where you find some kind of support in your favor, a signature, say for example, of the person who has given consent, because you have to prove that it was an informed consent. Then there is this 2010 legislation, Clinical Establishments Registration and Regulation Act of 2010, which ensures registration and regulation of medical facilities, standardizes healthcare practices to prevent unethical conduct, focuses on private healthcare transparency. One legislation which, though is not directly concern of orthopedics, but is a concern of the entire medical community, was passed in 2017. That was HIV Act. It's a long title, but is abbreviated as HIV Act of 2017. Now, HIV Act of 2017 says that if a doctor or a counselor who may be a non-medical professional diagnoses that the person or the patient is HIV positive, this status of the person as HIV positive can be disclosed under certain circumstances. There is a particular section, it's in public domain. There is this section 9. It talks about the HIV status of a married man. And it says that the counselor and the doctor must tell, once they detect that their patient, who is a married man and has a living spouse, is HIV positive, ask that, are you going to tell your wife that you are HIV positive? And if he says that I am not going to tell my wife that I am HIV positive, it's the duty of the doctor to divulge that status to his wife. But that can be done only, as I said, after counseling and asking him that whether he is going to do that. But one thing which is of utmost importance in this regard is that in case a married woman is diagnosed as HIV positive, the doctor may still not divulge that status. If she tells that if this status is known to my family, I would be subjected to physical abuse and all. So it's not only about medical diagnosis. The role which the law prescribes as far as the doctors are concerned are not only of those who would be carrying out medical interventions, but also caregiver, comfort giver, and also as professionals who would be ensuring that in case there are two conflicting interests, one which is very individual and private, the other which is public, certainly they have to choose that larger public interest. So I've been indicated to wind up. Thank you. Thank you very much.
Thank you, Pandit sir, for wonderful insight. I would like to call Dr. Manish Khanna sir to felicitate Dr. Pandey sir.
I'll request Dr. Dheeraj. So Dr. Dheeraj, to all the present Feiora, he's the topper of the last batch. So he's your mentor in that way. And I'm highly thankful that he has taken the time and accepted my invitation to be here to conduct this ceremony fruitfully well. So I'll ask him to present his views on the approach of the monoarthritis, which we'll going to discuss later on also in the course. Thank you so much. Please.
Thank you very much, sir. So approach to monoarthritis. So what basically is a monoarthritis? It is a joint inflammation that starts and it remains at a single joint. Monoarthritis, it can occur in a previously normal joint or in a joint that is abnormal due to previous joint disease. Now, the classification of monoarthritis can be acute and chronic depending upon the intensity and duration of the symptoms. If it is less than 6 weeks, it is acute. If it is more than 6 weeks duration, then we consider it as chronic. The most important part in approach of monoarthritis is history and examination. Whether it is articular, non-articular, inflammatory, non-inflammatory, number of the joints involved, what is the patient profile, age of the start of the symptom, what was the gender, race, familial aggregation, the complaint chronology, onset, evolution and duration, extent and distribution of the joint involvement, precipitating factors like trauma, drugs, antecedent infection or comorbidities, associated systemic features like fever, rash, myalgia and weakness. All these are very important points because then only you will be able to rule out the other diagnosis and reach to the proper conclusion. Now, a basic general criteria of the age that if it is young, it can be SLE, middle age can be fibromyalgia, rheumatoid arthritis, elderly mostly osteoarthritis. If it is female patient, it can be rheumatoid arthritis, lupus or fibromyalgia. In male, gout or spondyloarthropathy. In familial aggregation, it can be ankylosing spondylitis, gout, psoriatic arthritis, and osteoarthritis. Evolution, chronic, mostly osteoarthritis. Intermittent can be crystal induced or Lyme's disease. Migratory can be rheumatic fever, gonococcal or viral arthritis. If there is an axial involvement, it can be ankylosing spondylitis, tuberculosis, brucellosis, osteoarthritis, lumbar and cervical spondylosis. Now we'll understand it by a few cases. In first case, a 73-year-old man requires an urgent appointment for assessment of painful left ankle. This started suddenly 2 days ago and is so painful that he cannot put his foot on the floor. On examination, the ankle is red and significantly swollen, but the rest of his joints are unremarkable. He has history of 2 episodes of pain, redness and swelling of his right big toe, which settled over 2-3 weeks with antecedent rest. So what all information we have gathered is that there is a painful left ankle. History is of 2 days only. It is red, significantly swollen. Rest of his joints are unremarkable. So it is a case of an acute monoarthritis. Now, Differential diagnosis of monoarthritis can be septic arthritis, it can be crystal induced arthritis, traumatic, hemarthrosis, fracture, foreign body, ischemic necrosis, monoarticular rheumatoid arthritis. Some important things that we have to keep in mind is if it is a septic or crystal induced arthritis and fracture, because that need an urgent attention. So how to investigate? Basically, the investigation will be same for acute and chronic, but for an overview, we have to go for complete hemogram, ESR, CRP, renal function test, uric acid levels, rheumatoid serological markers, anti-CCP, ANA, complement levels, radiograph, and joint fluid aspiration. This is the key investigative and most definitive for diagnosis. This is just an overview of what can be appearing in normal, in non-inflammatory, inflammatory, septic, and hemorrhagic hemarthrosis. Now, a case 2. A 32-year-old woman describes painful swelling in second toe. This came on spontaneously 7 weeks ago. Examination of her other joints, including her back, reveals no abnormality of joint shape or function. While examining her joints, you notice scaling patched of skin with underlying erythema over her elbows and knees. She has had these 3-4 years back and has treated it as dermatitis with simple cream. More recently, she has noticed some flaking of a toenail on the end of the painful toe. The rest of the general physical examination is normal. So what all things we have? It is in second toe spontaneously for 7 weeks. There is a patch of skin 3-4 years back and flaking of her toenails. So this is a case of a chronic monoarthritis because the duration is more than 7 weeks. These are the few DDs of chronic monoarthritis: tuberculosis, psoriasis, brucellosis, fungal, syphilitic, sarcoidosis, and osteoarthritis. Most commonly, we'll be seeing the psoriatic arthritis. It is a T-cell mediated inflammatory skin disease associated with HLA-B27 positivity. Clinical features are mostly DIP joint are involved with nail changes, and nail changes are almost always there. It is an asymmetric oligoarthritis involving knee and small joints. Axial arthropathy can be a part, and arthritis mutilans. The clinical feature mostly are nail changes, skin changes, back pain, neck pain, and stiffness. So these are the few appearance. You can see nail pitting, onculosis with yellow greasy nails and horizontal ridging, dactylitis, telescoping. You can see, if you can appreciate this joint, it is pencil in cup deformity. This is very typical in psoriatic arthritis. Investigation, you should go for routine ESR, CRP, rheumatoid factor, anti-nuclear antibody, radiographs. In radiograph, we'll find these typical features like penicillin cup deformity, whiskering, that is marginal erosion with adjacent bony proliferation, small joint ankylosis, telescoping of digit, periosteoitis, and new bone formation at the site of enthesitis. Axial, you can see asymmetrical sacroiliitis. Tuberculous arthritis is another chronic arthritis that mostly you will encounter. It is a chronic granulomatous monoarthritis. It involves weight-bearing large joints, knee, hip, ankle. It can occur either in a disseminated primary infection or later reactivation in HIV or any other immunocompromised host. The diagnosis is by routine investigation, synovial fluid aspiration, culture sensitivity of synovial fluid, of synovial tissue, and radiographs. This is the FEMSTA triad. Here you can see there is a periarticular osteopenia, marginal osteophytes, and gradually narrowing of the joint space. Now case 3. A 50-year-old traveling salesman presents with difficult pain in his right knee after he has been driving for more than an hour. This has been coming on for past 3 years. He describes discomfort while walking upstairs and occasional pain in his knee and bed at night. Typically, he has a fewer symptoms earlier in the day, but his knee aches by the end of the day. On review of his musculoskeletal system, he has history of low back pain, pain in the ends of the fingers, the base of the thumb, and big toe. He had cartilage operation on his right knee at the age of 29 years after football injury. So this can be, 50-year male, difficult pain is right knee after he has been driving for more than an hour for past 3 years. Fewer symptoms in the day, but knee aches by the end of the day. So this is a case of a chronic knee pain. Now, what can be the differential diagnosis in case of chronic knee pain? Either it can be osteoarthritis. Why? Because there is a brief morning stiffness, Usually spare wrist, elbow, and ankle. In case of rheumatoid arthritis, there is stiffness, but it is of prolonged nature and it mostly involves the small joints. Bursitis, tenderness is outside the joint articulation. And if it is Encini bursitis, it occurs medial and distal to the knee with prominent nocturnal pain in the early disease. So osteoarthritis, as we all know, most commonly seen in elderly women. Commonly it affects the cervical, lumbar spine, hip, knee, BIP joints, base of the thumb, first metatarsal joint. Joints which are spared are wrist, elbow, and ankle. Pathogenesis, as all we know, it is loss of hyaline articular cartilage in focal and non-uniform manner. So what are the risk factors? Systemic factors are increased age, female gender, genetic susceptibility. Local environments are previous joint damage, bridging muscle weakness, malalignment, increasing bone densities. Loading factors are obesity, injurious physical activities. These are the treatment approaches. Mild and intermittent symptoms, only reassurance, non-pharmacological treatment. If there is an ongoing disabling pain, both non-pharmacotherapy and pharmacological treatment. Non-pharmacotherapy, mostly it is avoid the painful activities that overload the joint, improve muscle strength that bridge the joint, unloading the joint by using a brace or splint. And pharmacological therapy, paracetamol is the initial analgesic of choice. Intra-articular steroids can also be taken into an account. Surgical therapy is arthroplasty. So what is the take-home message? The first thing is this: you should listen to the patient very patiently. You take proper history and examine the patient well. Order relevant investigation, and most important, read your books thoroughly, because then only you will be able to conclude what exactly is the diagnosis. Thank you very much.
Thank you so much, Dr. Dheeraj. Any question anybody want to ask on monoarthritis? See, monoarthritis is a very important topic. Whenever you get a patient in OPD with a single joint, a knee joint or ankle joint, it is not always a knee joint is coming through, it may be a OA. If it is an ankle, it's not always, it may be a rheumatoid. So there are so many things which needed to be, worked up whenever you receive such a patient. So it is a basic thing. And I think it's the most common thing, because even in a clinical practice, it has been seen many times that a patient approach to orthopedic surgeon with a knee pain, and we say that it is a osteoarthritis. And that is why this orthopedic rheumatology subject has been created, to give this awareness. So that is the most important thing, and this lecture is very important. We're going to discuss it again and again, but still, if any question from you guys for any concept which you are still not being able to understand in the monoarthritis, I'd be happy to discuss it there. Fine, thank you so much. So I'll request Dr. Dheeraj, first of all, to come to receive a memento. Thank you so much, Dr. Dheeraj.
Thank you very much, sir. Now I would like to invite Dr. MD Kumar sir for his MD Kumar sir.
Good morning, all. I'm here to talk about the introduction and approaches to bone tumors. How to diagnose, not about the and basic treatments, not about the complications. Complications I can discuss later. There's so many things are there in complications. First thing is about clinical examination. Main thing is the history. You have to ask about the pain, swelling, the onset and progression, remission, and any other joint involvement. Pain is what type of pain, whether it's intermittent pain, and the swelling, whether it's increasing in size. The most of the tumor patient, they come to the OPD and seen by the general physician, and they'll say it's a local pain and they'll treat with analgesics. And 90% of the tumor patient, they come to us with either a pathological fracture or in later stages where it can be treated. I have seen more tumors with a fungating mass treated natively. So it's very critical to diagnose the tumor patient initially so it can be treated easily. But it's so unfortunate, all tumor, 90% of the tumor patients, they come to us late. So important thing about the pain, if you have any doubt, either any physicians, they see the patient, if you have any doubt, refer to a proper person who does tumor surgeries. But if you miss the early diagnosis, then it's very difficult to treat, especially in malignant tumors. Benign tumor is fine, but malignant tumors has to be treated the earliest. Then the examination part is number. How many tumors, a shape, size, character, the consistency. Most of the tumors will be, it's not like general surgery. You don't go for consistency, surface borders. Most of the tumors it will be hard and consistently, it will not be mobile. It will be fixed to the underlying structures. And the diagnostic thing is mainly by X-ray, CT, MRI, PET-CT, and bone scan. So these are the things with tumor comes, the age, sex, they have to see for single or multiple location and the morphology, all these things. Radiology is either coming to the X-ray, radiography, age of the bone. You have to look for number of lesions, location of the skeleton, border of the lesion, zone of transition, type of bone destruction, type of periosteal reaction, type of matrix, that is the composition of tumor tissue, and nature and extent of the soft tissue involvement. These are the few things you have to see here. The soft tissue extension, bony destruction, periosteal reaction. Then about the age. Aneurysmal bone cyst, chondromyxate fibroma, chondroblastoma rarely occur after age of 20, but GCT usually occurs after growth plate closure. Multiple myeloma, metastasis and chondrosarcoma rarely encountered in young age. Simple bone cysts usually occur in long bone before skeletal maturity. After skeletal maturity, they arise in pelvis, scapula, or calcaneum. But calcaneum, pelvis, scapula is very rare. I have seen only two patients of, I've seen two cases of osteosarcoma in a scapula. We have done a scapulectomy and we did a scapular replacement with the processes. Two patients in scapula. And the number of lesions. The benign lesions are usually at multiple sites like polycystotic fibrous dysplasia, endochondromatosis, multiple osteocartilaginous exostosis, and primary malignant lesions rarely present as multifocus lesions like Ewing sarcoma, fibrosarcoma, osteosarcoma, or chondrosarcoma. Malignant lesions indicate metastasis or multiple myeloma or lymphoma. These are the site of lesions. Osteosarcoma, chondrosarcoma, all these things are ABC, GCT, where it comes. These are the in immature skeleton and in mature skeleton. And this is in the spine. And you have to look for the epicenter of the lesion, whether it's a central, eccentric, cortical, parosteal, or it's intra-articular. These are the few examples of the epicenter of the lesions. How you have to look about it, all the tumors. Then you go for the border of the lesion. The border of the lesions are crucial for factors in determining the growth rate of the lesion, whether it's benign or malignant. The margin with sharp demarcation by sclerosis between the peripheral aspect of the tumor and the adjacent host bone is 1A, and 1B will be a margin with sharp demarcation with no sclerosis, and 1C will be an ill-defined margin with interface between lesion and host bone. These are the borders 1A, 1B, and 1C. Border of lesions, slow-growing tumors, lesions, sclerotic borders, and sharp outlines. Narrow zone of transition, black or white. More well-defined margins show biological activity. These indicates tumor, benign tumor. The malignant tumor will present in black or gray and white and rapid biological activity. But radiotherapy and chemotherapy of malignant tumors can alter the transitions. So there are few examples. This is in the distal femur, this is in the pelvis. The type of bone destruction, whether direct effect of tumor cell response to the host bone to pressure generated by the enlarging mass, cortical bone is destroyed rapidly than trabecular bone based on the it's into type 1, type 2 and type 3. Non-pathogenic tumor suggests benign or malignant. These are the bone destructions based on geographic, moth-eaten and permeative. Types of bone destructions, a few examples you can see here: uniformly destroyed or well-defined, slow-growing like giant cell tumor. This is an example of giant cell tumors in distal radius. This is a malignant tumor, moth-eating appearance, you can say it. This is the other one. It's an osteosarcoma. It's an ill-defined margin. Type of bone destructions is non-neoplastic lesions exhibit type 2 or type 3 destruction patterns. Example is osteomyelitis. Hyperparasitism causes permeative pattern. Often type 2, type 3 coexist in same lesions. Non-neoplastic lesions also exhibit type 2 and type 3 destruction pattern. Type of periostal reactions. Either it can be solid, continuous, uninterrupted, or it is discontinuous or interrupted. Solid means single solid layer, multiple closely opposed or fused layers of a new bone attached to the outer cortex or cortical thickening. Solid buttress is ABC, chondromyxoid fibroma. Solid longitudinal is osteoma, osteoblastoma. Solid undulated is osteoarthropathy or periostatus. These are a few examples. This is an osteosarcoma seen in the distal femur, and this is a proximal femur. This is a Ewing sarcoma with the onion peel appearance. This is uninterrupted periostal reaction, interrupted periostal interruption in various tumors. The type of matrix. The matrix represents the intercellular material produced by the mesenchymal cells. Could be osteoid, chondromyxoid fibroma, or collagen material, useful to differentiate between chondroblastic and osteoblastic form. Presence of irregular, not fully mineralized bone matrix with or adjacent to the bone destruction suggests malignant lesion. Cottony or cloud-like densities within the medullary canal and into the adjacent soft tissue suggest malignancy. So these are a few examples. This is a type of matrix: stippled, flocculent, rings and arcs. Type of matrix calcifications is the enchondroma, chondroblastoma, chondrosarcoma. Radiologically, difficult to differentiate between osseous matrix and cartilaginous matrix. Osseous are more organized and structural. Cartilage is more amorphous and calcifications. These are a few examples here. Other main thing is the soft tissue involvement. Usually in benign tumor, there won't be any soft tissue involvement, but malignant tumor, mostly they have a soft tissue involvement. Few exceptions will be in malignant, will be GCT. Osteomyelitis is non-neoplastic condition manifest with soft tissue component. So these are a few examples how to look about the malignant tumor, how it will be, and in benign tumors. These are the differential diagnosis: primary soft tissue tumor versus primary bone tumor. So how this will be in benign lesion and malignant lesions. So these are the osteoblastoma. Then about the bone scan. Bone scan is the indicator for mineral turnover, enhanced deposition of the bone, seeking agents in areas undergoing change and repair. Bone scan is useful in localizing the tumors and tumor-like lesions. Example, Langerhans cell histiocytes, metastatic tumors, more than one lesion is encountered. Monostotic or polystotic, staging of neoplasm. Localized small lesion like osteoma which may not be visible in X-rays can be seen in bone scan. Also, it's also useful in assess the response to chemotherapy. Again, CT will be helpful in to find the extent of the bone lesion, to find out the cortex, trabecular bone, marrow cavity, and soft tissue spread. These are a few examples. And the MRI again will compare to CT. Soft tissue will be you should usually see the soft tissue expansion, whether the neurovascular structures are involved and the adjacent tumors and neurovascular involvement. MRI is very sensitive in detecting the extent of the tumor disease. These are the few examples. And the grading will be grade 1, 2, and 3. Well differentiated is a low grade, moderate differentiated, and poorly differentiated will be high grade. Then how to diagnose a tumor. Commonly it will be through FNAC or a true cut biopsy or open biopsy. True cut biopsy useful in anatomically inaccessible areas like spine and pelvis. Minimal soft tissue damage or contamination. Capsular invasion is small, so bleeding is minimal, literal, no anesthesia. Under CTR, USG guidance for proper localization. Disadvantages is amount of tissue will be very small for histopathological purpose. Heterogeneous lesion, relation of bone tumor to soft tissue cannot be commented. Hard tumors, optimal samples cannot be obtained. And in open biopsy is done by needle biopsy, doesn't correlate for diagnosis. Most of the time when you do a true cut biopsy, the sample will be very small and the pathology will report back to us with, they'll say, insufficient sample. In that case, you have to go in for an open biopsy with the smallest incision, direct path to tumor to reduce the soft tissue contamination, longitudinal incision at the extremities, so better for final procedure. Use of tourniquet, it depends upon the surgeon whether to use tourniquet or not. Some people they use tourniquet for open biopsy, some people they don't use tourniquet. Tumor capsule to be closed after the biopsy, avoid plain to neurovascular bundle. Open biopsy again is do not violate major flap structures, because we have to use later once the diagnosis is there, whether it was an osteosarcoma, then you have to do for later reconstruction. You do not violate the major flap structures. Use a knife of curate to take sample. Obtain multiple samples, minimum 4 to prevent heterogeneous variation. Frozen section is better. Surgery, diagnostic is open biopsy or external biopsy, definitive and palliative. Now, most of the tumor surgeries, the treatment of choice is limb salvage. We do a limb salvage surgery where there will be adequate margin for resection of tumors obtained with low risk, 10% of local recurrence. Joint and cartilage are carefully assessed for involvement. Functional outcome of the limb is better than what can be achieved by amputation. Primary goal is painless limb, cosmetic appearance. Phases of LSS, tumor resection, reconstruction of bone, soft tissue, and muscle transfer. Limb salvage is contraindications. Invasion into neurovascular bundle. If there's a neurovascular bundle involvement, the limb salvage surgery cannot be done. Then no other choice, you have to go in for amputation. The other thing is if it's a fungating tumor, we can't do a limb salvage surgery. You have to do an amputation, multiple compartments or extensive soft tissue involvement, extensive skin involvement, and there's a pathological fracture where there's a risk of recurrent increases several folds. Then the plane of dissection is within the tumor mass, removing only a portion of lesions, a marginal excision. Here is the plane of dissection within the tumor mass, a marginal portion only is removed. Skip lesion, the capsule may be left behind, like in ABC or simple bone cyst. Wide resection is done mostly to malignant tumors like osteosarcoma, Ewing sarcoma, or chondrosarcoma, where the normal 1 to 2 centimeters, so up to 1 to 2 centimeter bones are removed. Normal bone is removed, depend upon the tumor tissue and the tumor involvement, and high-grade aggressive tumors. Radical marginal excision is removing the entire compartment of tumor spread. Skip lesions also removed, no recurrence, most malignant tumors. Amputation is less frequently performed, yet the gold standards to prevent local spread. Most common applied to end stages of malignant lesions to completely excise the tumor. Again, chemotherapy and radiotherapy plays role in tumor in osteosarcoma and Ewing sarcoma. Usually will give in osteosarcoma will give us total of 6 cycles of chemotherapy, 3 cycles pre-op and 3 cycles post-op. Once 3 cycles chemotherapy is finished, wait for 3 weeks, then you go on for the surgical procedure, the limb salvage surgery. Then after the suture removal, you can go for 3 cycles of other chemotherapy. Then for Ewing sarcoma, usually we'll give 12 cycles of chemotherapy, first pre-op 6 cycles and followed by surgery. Then we'll give a 6 cycles of chemotherapy. Chondrosarcoma, usually they don't respond to chemotherapy or radiotherapy. Usually we don't give anything, we'll go straight in for surgeries. Radiotherapy, usually we'll give for recurrent lesions. In osteosarcoma, Ewing sarcoma, when we get a recurrent lesion, we go in for radiotherapy. So these are radiosensitive tumors, Ewing's, lymphoma, myeloma. One case example recently we done is a 13-year-old girl with a diagnosis of right proximal tibia osteoblastic osteosarcoma. She was given a diagnosed by a small open biopsy and she was referred to a medical oncologist. This is the this is the X-ray. The proximal tibia, she was given 3 cycles of chemotherapy. This is the MRI pictures. Minimal soft tissue involvement was there. This is the surgery we performed. We removed the proximal tibia. We help of the surgical oncologist with the neurovascular bundle was released and we did a expandable processes. This is the expandable processes for this girl. After 1 year, we'll see the shortening. We can, with a small incision with the key, we can expand the processes. Once after the skeletal maturity, but definitely she'll be need a revision surgery. Thank you.
Thank you very much, sir. Now I would like to call upon Dr. Srinivas, sir, for please.
So now we have almost covered more than two-third. And before moving further for the 2 more guest lectures, there are some important tips which I want to give to my new 6 fellows. So here the 7 fellows. Now, a good news is, like, I was just reviewing all the examination portion, the things which we have gone through morning. All of them are going to clear this time, and we'll like to give the certificates also this time here only. And the reason for this was a difficult task because 9 people had applied last year and 6 have submitted their work. 7th was on a mercy grace, so it was been accepted. So it is just like a same thing I'm repeating every time. This fellowship program, I don't know how it has been started, how it is moving ahead. Now it is on the second stage that we are going to conduct orthorheumatology plus regenerative fellowship with the Law University. No fellowship in our country is with the government institute associated. No fellowship is there which has been endorsed in such a manner. And we, for the passing out fellows, we like to tell that from this time onward, we are going to do a clinical work with the ethical clearance, committee clearance with all the medical colleges, all the fellows who are going to come. Definitely, they will be introducing their work themselves post lunch. But before that, some few things which I want to emphasize is here. This is the format. the format I have already submitted to you, and I'd like to share here also, so that should be clear to everyone with their permission. Should come. I think it should come. Can this be? Yeah. We can see this here? Yeah. Is it here? Fine. Yeah. Thank you. So this is the first page. Now, in the second page, it has been mentioned the course detail. What are the things? Let me come to the straight point. So after your guide and co-guide name writing here, date of allotment. So date of the allotment would be the same date when we have finalized that your topic is clear, right? That date, I don't remember right now. Date of registration of synopsis is today. Topic, you all know, ethical clearance date to attach the certificate. So few of you have already done your ethical clearance. Those who have not done, it is fine. Within 1 month, we should have it. We're going to have only 2 reviews of the synopsis. First review will be after 1 year, or rather after 6 months, and final review will be after 1 year. Date of submission of synopsis that you will submit after 1.5 years, right? Any other research work which you want to write, presentation of the work in the conference. So whenever you're going to come to your Indian Stem Cell Study Group conference, Indian Orthopedic Rheumatology conference, what you're going to present is have to be kept it here. So this is a declaration, and I've already WhatsApp you the exact soft copy. Few important thing which I want to emphasize here is, now this is the research proposal which you have submitted, and this you have to place it here in black and white. Now presentation of the research work done. Whatever work you're going to do in another 1.5 years in IACSG or IRO conference, you can present that work for an open discussion. And I'll again say, we have a lot of, I think we have OA cases with the PRP and BMAC. It is not very important that to give a positive result. Let come out with a negative result also. So it should be very much open to have a lot of criticism that we have not been what the seminar you're going to present, it is to be placed here. And then this is the case details. So in the last batch also, they have a little improved from the previous batches with the case presentation. Whatever cases you're going to do, we're going to discuss it, because each case is different case. Suppose you are placing BMAC in a OA knee. Are you sure it is a OA knee, or it's a knee with a CPPD? Whatever it may be. So every case is a different case. So whatever, of course, you're going to take 20 or 30 cases for your study, but we can have a summary of that. And last but not the least is, in the end, you can write it down as a delegate podium presentation, what you have done. In podium presentation, what you have done in the conferences. Observership, yeah. From this year, we have, as usual, I was not able to send the presentation. Surat, Chennai, there are few centers where we have a tied up for observership. So you guys can go in a batch or something like that. We'll arrange for that. So as to have a more advanced idea about what the orthobiologic is all about. And they are the online lectures. One more thing, I'll just give this paper back to you all. Whatever the presentation, the publication you're going to give, it has to be in a PubMed, Scopus, or anything, any journal with having impact factor more than 2, minimal, right? So that's all. And now I'll request.
I would like to call Dr. MD Kumar sir, please. And I will welcome Manish Khanna sir to give the moment.
So this pain management, I am dealing with pain management. Actually, it is a part of rheumatology. When people are doing intra-articular injections and shoulder injections, so you people can do epidurals also. So I have been practicing since 25 years. Lumbar epidurals, and I learned with my own interest, and I have been practicing. So I think 5 years back I have started even cervical epidural. A little bit risky, but if you are cautious, I think you can produce excellent results with cervical epidurals. So that's what I am going to speak on. So, yeah. See, use of epidural injections in the cervical, thoracic, and lumbosacral spine for both diagnostic and therapeutic purposes has developed an important part of a comprehensive interdisciplinary approach to spinal pain. So, diagnostic and therapeutic. In acute disc injury, with or without radiculopathy, therapeutic injections can help manage patient's pain without reliance on oral analgesics. So history-wise, if you see in 1901 for low backache, a sciatica, injection of cocaine were used. Then Wiener injected mixtures of procaine, ringer solution, saline, and liquid petroleum. In 1930, Evans published good results in 22 of 40 patients with unilateral sciatica treated by caudal epidural injection with procaine and saline. In 1955, Bowden et al. First injected corticosteroids. This was followed in 1957 by Levray, published report of treatment of low backache by epidural steroid injections. In 1984, Shulman et al. And Kachlau-Braha published for cervical epidural steroid injections. And there is no historical information on thoracic epidural steroid injections. So mechanism is primarily mechanism of action is due to potent anti-inflammatory properties of the corticosteroids. The marked pain relief noted with epidural steroid injections for acute radiculopathy may also be due to the stabilization of nerve root membranes by the corticosteroid suppressing the ectopic neuronal discharges, which can cause pain and paresthesias. And corticosteroids may also exert anesthetic action. So identification of epidural space is important. When the needle enters into the epidural space as compared to the marked resistance to the injection within the tough underlying ligamentum flavum and other dense soft tissues. So this is so when you enter the needle, so after passing soft tissues and ligamentum flavum, so immediately a tough ligamentum flavum, you can feel that that your needle is passing through the ligamentum flavum. Once you pass the ligamentum flavum, you will get the loss of resistance syringe we use. So immediately the air enters into the epidural space. So in cervical epidurals, so usually we inject 5 to 8 ml of most appropriate volume. 8 ml injected at the C7T1 interspace. Usually it spreads up to the C3 and C4 level. The rate of epidural injection does not appreciably change the ultimate spread of injection. Faster rate of injection, more pain during and after the procedure. And before planning epidural injection, patient should be asked for diabetes mellitus, any infection and immunodeficiency, any allergic reactions, possibility of pregnancy, and any blood clotting abnormalities or treatments. And cervical epidural injections are more effective in patients with pain of discogenic origin, especially if the condition is acute, involves a significant disc bulge, and is associated with significant upper extremity radicular pain. Several studies documented better results, better for cervical epidurals given within the first 3 months of neck pain with or without radicular pain. So midline interlaminar approach is ideal. Usually 18 number needles are not advised for cervical epidurals, but the 18 number epidural needles which are available in India, so it is not advised for cervical epidural. I get 20 or 21 gauge from Germany, so we use for cervical epidurals only 20 or 21, because accidentally if you puncture a cervical epidural, so that may cause a neurological deficit. So that's why 18 number gauge is very not advisable at all in cervical level. Factors must be considered when scheduling the patient initial cervical epidural: failure of less invasive interventions, and severity of patient's pain and need for pain control, the use of or misuse of oral analgesics, patient ability to perform self-care activities, avoidance of hospitalization, and facilitation of active rehabilitation, and allowance of an early return to work. Cervical epidurals are usually performed in about 6 weeks after the onset of cervical discogenic pain with or without radicular pain, and may be given if alternative pain management techniques are failing, and MRI is required before planning for epidural. Epidural can be given based on clinical judgment also. Complications, local anesthetic complications, you should be aware of all complications of local anesthetics: CNS toxicity, circumoral numbness, disorientation, lightheadedness, nystagmus, tinnitus, muscle twitchings, and corticosteroids, triamcinolone or beta medicine, insomnia, mood swings, euphoria, depression, post-injection pain flare, facial erythema, fluid retention, hypertension, congestive heart failure, hyperglycemia, headache, gastritis. So these are all very few complications may be encountered. Contraindications are main any patient if is having any anticoagulation or bleeding disorder, suspected local or systemic infection, any neurological deficit. When neurological deficit is there, we should not give. I don't think it may help. And anaphylactic, allergic anaphylactic reactions, anaphylaxis occur most often within 2 hours after the epidural injection. Closed patient monitoring is important after epidural injection. Medical complications, there is episodes of vasovagal syncope, which requires treatment with IV fluids and ephedrine, superficial infection at the site of injection, and intermittent nausea and vomiting. Minor complications like headache, dizziness, transient hypertension, nausea, transient aggravation of neck pain. Dural puncture is associated with the lumbar epidural. I think you can do, you have to manage with the blood patch. So if dural puncture is there, happened, immediately you have to aspirate 5 to 10 ml of blood from same person and inject into the epidural space. So cervical, it's you have to do very cautiously only. You should not puncture, otherwise the patient may develop neurological complications. Epidural abscess and hematoma, it is very rare, is associated with the use of epidural catheter. Usually we don't use epidural catheter. Patients with pre-existing infections or severe neck pain, fever, chills, treatment is surgical. Then we have to do the laminectomy and debridement. Any medication for blood clotting mechanism taken before the epidural injection could increase the risk of epidural hematoma, heparin or coumarin aspirin. So we have done the study to know the efficacy of epidural steroid injection in cervical chronic discogenic pain. Then I have done 300 patients treated with cervical epidurals out of 198 males and 102. All patients were treated with cervical epidural in midline approach, C7 and T1. And Crawford and Toffee needles are blent, designed specially for epidural injections, and winged needles with a hanging drop. So we, after passing the needle, we inject saline into the needle. So once the saline is sucked into the epidural space. That means we have entered into the epidural space. So betadine, sterile drapes, local anesthetic. So you have to you have to inject the anesthetic into the track. So these are the materials. So I inject. Right? Yeah. Neck bending position. Okay. Yeah. Now the drop is sucked inside. So inclusion criteria: chronic persistent neck pain with or without radiculopathy for 6 to 8 weeks, failed conservative management. Exclusion: cases without appropriate diagnosis, worsening and progressive neurological deficit. Significant pain relief is considered if 50% of pain reduction is seen at 3 months, 50% patients having significant pain relief after the procedure immediately, and function assessed through neck disability index and pain rating score. In our study, almost 80% of pain relief is observed in 90% of the patients. 10% of patients required second epidural after 1 month. Follow-up done up to almost 5 years. Physiotherapy is advised after 2 months onwards. No complaints of recurrence of symptoms, and no patient required surgery after epidural treatment. Almost all patients reached to their normal activities. In our study, dural puncture was not observed. So cervical epidural steroid injections are appropriate for OP setting provided all necessary resuscitative equipment is available: oxygen, intubation equipment, emergency drugs, IV access, monitoring pulse, BP for every 15 minutes, observing for 45 minutes, follow up a phone call after 24 hours. Cervical epidurals are very effective in chronic neck pain and with or without radiculopathy of upper extremity, and may not require surgery just by MRI findings. Economic: patient can reach their normal activity after 4 to 6 weeks. In many patients, we can avoid surgery. Skill and confidence is required for giving cervical epidural injection. Otherwise, patient may develop neurological complications. Thank you. Thank you.
Thank you very much. I would like to call Dr. Manisha to felicitate Dr. Srinivas. Now, I would like to invite Professor Dr. Partha sir.
Partha Sarkar is Secretary General of Indian Orthopedic Rheumatology Association. So be ready with him. He will take you to the next height.
No, thank you, Professor Monish Khanna sir, because he has given me a very big opportunity to be here as a in this Feiora exam, because it is the only fellowship in India, I think, that is university recognized. If I am not wrong. So this is the very good initiative, and this will effectively help you in your orthopedic practice, because nowadays it is the aging is a now problem for the patient who are not carrying their joints, because the mobility is restricted. So the age, the life expectancy has been increased. So we should be very much careful to preserve their joint. So the knowledge of this orthorheumatology is very important in these regards. So when I must thank our external examiners for accepting me as an examiner, because they have a very good talk before me. Now it is my turn, because when I have taken the charge of this Indian Orthopedic Rheumatology as a Secretary General, I have prepared one thing, that is the what is the marker, because this is the topic of my topic today, because these markers is the very important part to keep the disease progression, to stop the disease progression, or to help the patient to decrease the disease situation. So we all know the definition. This is not at all required in this platform. So this is the different stages. This is the healthy joint. There is a first of all, then the synovitis, then panas, then fibrous ankylosis, and then bony ankylosis. So we should prevent this complication. So this is a very difficult picture that is showing the different indicators and different things. So I will make this thing easy. So now we only found these inflammatory infiltrates in joints, synovial joints. So why not in other places? So this is, then the thing is that there is in this synovial inflammatory infiltrate will cause this subchondral bone damage. There is an inflammatory cyst, there is a erosion, there is a loss of this joint. So why this is? So to make this simple, this inflammation is initiated by any trigger point that will cause this cascade of various destruction by these leukocytes and these cytokines. These are the markers. So to mediate the local inflammation and the pro-inflammatory cytokines like interleukin 1, tumor necrosis factor, interleukin 6 plays important role in activating inflammatory cells like neutrophils, macrophages, and monocytes. So in brief, the different inflammatory marker sources. There is no pointer, so I will show you that there is a vicious cycle. That once this inflammation has started, this tumor necrotic factor, this cytokine will increase. This will lead to this synovial cells to hyperplasia of these synovial cells. These are the things that will increase this Rankel inhibitor that will cause this bone erosion. And another instances is that this will also create this protease. This will cause this cartilage damage. So the disease is within the joint, that is the synovial cells. These are the hypertrophy of this synovial cell will cause these two effect. This is the Rankel and the protease. This will cause this cartilage destruction and the bone destruction, and this will be, so the disease is within the joint. So we should prevent this hyperplasia of these synovial cells. That will definitely reduce this bone erosion as well as cartilage erosion. Now, what is the cause of this citrullination? That is the own antigen is behaves like a foreign body. This is caused by this citrullination of the antigen, and this citrullination is caused by three sources, as we have gone through this literature. That is the genetical. Most of the cause is the genetics, because this citrullination will lead to formation of these autoantibodies. Smoking, and there is gingivitis due to Porphyromonas gingivalis. There is a bacteria. And another thing I have already discussed, this synovial cell. This synovial cell will also help this citrullination of the own antigen that will produce this antibody. Now this is the antigen. This is the citrullination has been done, and this is the antigen. This antigen has been presented to this T cell, and this T cell now will activate this plasma cell, and this plasma cell will produce these two antibodies, that is the anti-CCP and the rheumatoid factor. And this will now, why they enter into this joint? Because there is a vascular permeability. There is an increased vascular permeability. There is angiogenesis in case of inflammation. So this antibody will enter into the joints only, and this will produce different effects. And there are the various systemic effects also. These are the cytokines that they will cause this liver problem. There is the increased CRP. There may be anemia also, and there may be the chance of this is the due to this blockage of these vessels in the brain or the in cardiac muscle. This will cause infarction as well as stroke. And there is a very good link with this depression, because this cytokine will also have some depressive effect on the brain also, as we have already discussed. And there is also osteopenia. This is due to this cytokines. So we should keep these things very limited way, so that this will not produce this kind of things. And there will be osteopenia, there will be muscle fatigueness. So these are the different extra articular disease. So what are the inflammatory markers? So do we have a primary inflammatory markers? There are 4. That is the C-reactive protein, ESR, leukocyte count, and the cytokines. That is the tumor necrotic factor, alpha, and interleukin 6, and others. So this is the current classification criteria of rheumatic factor, partially rely on the acute phase reactant, C-reactive protein, ESR, and autoantibodies, including rheumatic factor and antibodies against citrullinated proteins. So what is the CRP? CRP, as we have already said, this is produced by the liver, and this has been increased by these interleukin 6 and other cytokines that will produce these CRPs. So there is a various levels, as we have already you will know this. And these higher CRP levels are associated with greater rheumatoid disease activity, and this is based on the 28 joint. There is a DAS28 score, and the disease activities such as swollen joint count, patient reported measures including functional status. There is a health assessment questionnaire score. There is morning stiffness, fatigue, pain, that has been associated with this. So the disease activity is clearly associated with this CRP. And as it is also, there is a elevated CRP levels are also more general predictive value for the radiological progression. So this CRP is also correlated with the radiological progression. Now the turn is of the ESR. This ESR is very commonly, we have done this ESR in each and every patient. So this is a very commonly done test, and this will indicate and monitor and increase inflammatory activity within the body by one or the more conditions such as autoimmune disease, infection, and tumors. So there are the various conditions when this ESR will increase. So this sensitivity of this test is high, but the specificity is very low. Even as we have already discussed, 10% of the rheumatoid factor patients have, and 20% of the polymyalgia rheumatoid patients have ESR level that may be within the normal limit. And there are other things, that is the tumor necrotic factor. It is also known to be involved in the pathogenesis and some inflammatory autoimmune diseases. In rheumatoid arthritis, tumor necrotic factor secreted from the macrophage, as I have already discussed, and this will cause this synovial fibroblasts to, that is the synovial cells, to proliferate, and this will again promote this inflammatory activity. And this interleukin 6 is the one of the major pro-inflammatory cytokines responsible for immune response activation. And interleukin 6 is involved both in the immune responses and in inflammation, hemopoiesis, bone metabolism, as I have already discussed. These are the various side effects of these cytokines. So there is a correlation, that is the CRP is more correlated with this RA than ESR. And these are the various markers. There are numerous markers, and now there is a cellular and genetic markers are also available. So this is the latest development, and they have the progression that can be monitored by these inflammatory markers, and this will also help us to monitor the inflammatory, the rheumatoid arthritis disease. This we should measure this CRP and the DAS28 score regularly. In early active rheumatoid arthritis, measure CRP and DAS28 monthly until treatment has controlled the disease. through the level of previously agreed with the person with rheumatoid arthritis. And in case of satisfactory, we can say, tell them when to come, how to, when to ask our suggestions or the advice, and we should also monitor the drug intake, because this drug is doing all the things better. And there are other challenges and limitations, that is the other comorbidities activities with CRP. As in rheumatoid arthritis, there are cardiovascular comorbidities, as I have already discussed, metabolic syndrome, there may be diabetes mellitus, there may be pulmonary disease, and most importantly, depression. Depression is highly prevalent in case of the rheumatoid arthritis patient. So thank you for your presence here.
Thank you very much, sir. I would invite Manish Khanna sir to facilitate Dr. Parthu. Now I will welcome all the new fellows. Dr. Dattatreya Sitaram.
We'll request whenever the name is being announced, you come and introduce yourself and then take a most prestigious Feiora badge. See, please come over. So this fellowship was being started with the 19 candidate in first batch. Then it was moved to 15, then 12, 9, 7, this time 6. So we are decreasing the fellowship because the criteria are becoming more stringent gradually. So let's see how the things work up. Please introduce yourself.
Good afternoon, everyone. Thank you very much for this opportunity. I'm Dr. Dattatreya Sitaram. I'm currently doing FMB arthroplasty at Bridge Candy Hospital, Mumbai. And it's a great opportunity to learn more about orthopedic rheumatology as well as the orthopedic orthobiologics. And I intend to learn from all of you and make best use of this fellowship.
Next is Dr. Mohammed.
Good afternoon, everyone. I'm Dr. Ashik from Chennai. I'm currently working as a senior resident in orthopedic department in ESI Medical College, Chennai. So I'm happy to be here, to be part of this Feiora Fellowship. I'll be thanking Dr. Manish Khanna sir and all the delegates here, my colleagues also. And I'm happy to come along with my HOD sir, Dr. MD Kumar sir, who's also present here. So under the guidance of sir, I've already been practicing few injection orthobiologics in my institute. So using PRP, BMAC is doing. So I want to extend more knowledge into this. So by combining this fellowship, I'll be able to get more insight about what exactly we are doing. So to improve the better results to the patient. So I'm very happy to be here. Thank you.
Gautam.
Very good afternoon to one and all here, sir. I'm Dr. Gautam Krishnan from Coimbatore. I'm working as a senior resident in Department of Orthopedics in KMCH Medical College. And I'm very much thankful to Manish Khanna sir to be a part of this Feiora family. And thank you, sir. And thank you so much for the team, sir.
M. Gokula.
Good afternoon to one and all present here. I'm Dr. Gokulakrishnan from Chennai. I'm currently working as senior assistant in ACS Medical College. I especially thank Dr. Manish Khanna sir for giving me the opportunity. And I also thank my guide, Dr. Naveen Jayaraman sir and Madan Jayaraman sir, who just who only those two great people initiated the idea of orthobiologics in my life. Okay, we are currently practicing the PRP and PRF augmentation in meniscal repair and also arthroscopic treatment. So I'm thankful to them.
Hello everyone, this is Dr. Mir. Thank you, Manish sir, for giving me this opportunity. I've completed my orthopedics, now I'm practicing at Region Cure Hospital, Hyderabad. I wanted just to create the lacuna which has been created from long time regarding this the rheumatology part, which our orthopedicians have left a long time, like from 4 to 5 years. That lacuna I wanted to get it filled. So I found this fellowship so helpful. Thank you, sir.
Good afternoon, everyone. I'm Dr. Vaibhav Jain, working as an assistant professor in Gandhi Medical College, Bhopal. I would like to thank Manish sir for giving me this opportunity. I'm practicing orthobiologics, few of the like PRP in knee joints and AVN, and practicing rheumatology also. So this is the platform for learning more and expanding my knowledge into it. Thank you.
Thank you very much. Now we'll be dispersing for lunch, and by 2 o'clock we will gather here again. Thank you.
For lunch, we'll be going to the dining hall in the guest house. Yeah. So few of the vehicles are there. So if you can accommodate, otherwise you can walk in this nice campus. I think the temperature is also not bad. I'm not out right now, so I don't know actually. In the morning, it was good. Thank you so much. Already mentioned, this time we are going to give the projects, research projects to the Feiora fellows, where it has to be cleared by ethical committee, institutional ethical committee. Indian Stem Cell Study Group is in process of making its own ethical committee also, which is DCGI registered. So soon if it will be done, then it has to be submitted to that also, so that the proposal, the work would be totally authentic in the eyes of Indian laws, right? So over to Dr. Dattatrita.
Good afternoon, everyone. I'm sorry because of some, like sir said, some ethical and research advisory constraints. I'll not be able to share all the details, but I'll briefly explain about my project, what it's going to be. So it's a microfluidic device that we are designing, which will act as a knee joint, synovial knee joint, on which we're going to test the effect of the microbiome on the knee joint. So in the earlier talk, we have seen how the gut microbiome is influencing and having a gut-brain axis. With this study, we're going to have establish whether the microbiome has any role in pathogenesis of various diseases, or uh, also identify certain therapeutic targets for treating these diseases. So this is a multidisciplinary team that we have, and we have microbiologists, pathologists, and engineers, and stem cell experts, and orthopedic surgeons. And we have obtained the ethics committee approval and research advisory approval, and we have already done a pilot study on the existing microbiome in the Indian patients. So far, if you look at the microbiome literature in the human knee joints, we only have the Western literature. So that's going to be, that pilot is already done, and on that we are subsequently building these multiple phases. So the first phase in this study would be to fabricate fabricate a device. It's called a microfluidic device, which essentially has different hydrogels, and each hydrogel is for one cell line. Okay, so you have chondrocytes in one layer, you have the cells for the bone, that the osteocytes, osteoblasts in one line, then you have the synovial fluid in between this, and then we will assess these inflammatory markers that we have seen in osteoarthritis and rheumatoid arthritis, and then we will introduce this microbiome that we identified in the knee joint into this and see their interaction. So this is in gist about what we are planning for. So
this is to be done in rats, or this
no,
is,
no.
yeah.
So this concept of doing this device itself is to eliminate that animal research,
Okay.
and also shorten this entire bench to bedside research, where if we can establish whether this microbiome is actually causing this problems of prosthetic joint infections or any inflammatory cascade, that we have these different hypotheses that we already have in rheumatoid. Also, if you see, there has been some literature that it could be from bacterial origin, but nothing has been validated. So this is not going to be on animals, sir. This is going to be on a device, and that is called as microfluidic device, and it is also called as organ on chip. So this is a synovial joint on chip, that what we're going to do. So that is the plan.
This you are in right now. You are in which place? This has been attached to Manipal.
No, I'm in Bridge Candy Hospital.
Right.
I was in Manipal before going to Bridge
So
Candy.
this is to be done in Breach Candy.
Yes, this is a project that we have taken up in Breach Candy, and the pilots already have been done in Breach Candy, and these subsequent phases are also planned in Breach Candy, although before this Feiora fellowship. But right now we are planning, as I explained, this has different phases. So first phase is fabricating this device, and phase 1B is validating the device, and then phase 2 is having this microbiome that we harvest from the knee joint into this device, and phase 3 is actually seeing the clinical implications of this entire process. So this is a multiple phases. So
what are the different stages of these phases?
Yeah, so we have month 1 to 3 is for the chip design and fabrication and optimization of the chip. So month 4 to 6 is for the seeding of the chondrocytes and synovial exposure and microbiome integration. And month 7 to 9, analysis of inflammatory response and matrix degradation and regenerative potential. And month 10 to 12 is comparative validation and osteoarthritic samples and data analysis. This is a tentative plan, but when we looked at the literature, we have data for organ on chips, but very limited data for the joint on chip. Organs we have for liver, etc., but joint on chip is a recent novel development that is happening in a rapid pace. And second is, we have microbiome that is already studied for the gut. So joint microbiome itself is a new field, and here the complexity is that we are trying to take these two novelties and come up with this microbiome effect in this joint on chip. So which is a very novel study. That's why there are certain things that have been instructed not to disclose. So these are the limitations. So in this Feiora fellowship, I'm aiming to do a review for this fellowship. It could be the objectives for the review are to identify the best practices to design this chip That is the first objective. And second objective is to study the different microbiomes. And third objective is how to integrate this. So at the Fiora, my aim is to stop at the review level, because these designing, IPR, and ethics committee, etc., are already been started, and it's a multidisciplinary team where the institution may not agree for me to integrate that into the Fiora. Right, sir. Right.
Thank you so much. Any questions? Anything anybody wants?
Not ESRCRP, like cytokines, like, yeah. Yeah, so I can run the process of what we actually do. So just so when we fabricate, it's a 3D printed model. Okay, so which is like a, it's called as PDMS, polydimethyl siloxane. So in this, we will have multiple hydrogels. So each hydrogel is one layer, like I mentioned, the cell line. And to this device, what we do is we incorporate these our patient samples of chondrocytes and the synovial cells, etc. And then we integrate the microbiome. So this is just first we're building the device. From here starts the testing. So the first testing would be the mechanical testing. So there is a way to load these devices and assess whether this particular patient is more prone compared to the other particular patient for the arthritis. So with that, what we can see is we're actually going personalized therapy, where so far we all have studied that in our textbooks, that genetically linked or multifactorial. So this study, we're trying to bridge that gap. So after mechanical testing, we do the biological assays. In biological assays, we have the inflammation and degradation that are tracked via cytokine and matrix assays. So there are markers which can be tested in these chips itself for the biological assays. So unlike in patients where we draw the blood and see, in this device itself, the technology allows us to assess and evaluate all these parameters. That too in multiple chambers. So there are chambers that are there in this. So we can have like multiplied 32, 64, etc. That is a little technical. From in a biomedical engineer would better explain that. So after biological and mechanical testing, we compute and analyze the statistics and try to draw clinical inferences. So the utility, I would like to conclude with the highlighting the utility of such studies is, first of all, it is very novel, not just in India, across the world, I would say. And second is, if we are successful in this, we would be able to identify the targeted therapies, be it a prosthetic joint infections or even sometimes like diseases like as common as osteoarthritis and rheumatoid arthritis. And then we'll be able to prove or disprove this gut cartilage axis. So we have seen the gut brain axis. So there is this hypothesis that PGI is because of the gut microbiome that is causing the knee microbiome, and knee microbiome is flaring up as an infection. So that is still an hypothesis that has to be disproved or proved. And third is, it is going to be cost effective alternative. If let's say we need to run all this battery of tests on physical patients, then it involves a lot of effort, time, and money. So these devices, the technology is so much advanced that we can just print these devices like any other 3D printing tools that we're using in our day-to-day orthopedic practice. So it just needs multidisciplinary team, and our hope is to do this pilot and write some grants for the government like DBT, DST, or ICMR, and then take it forward. So back in our hospital, our plan is to first build 10 chips and then validate the osteoarthritic model, then the microbiome thing. So it's a long run that we're going to go for. For Fiora, the main objective is to have a review, like I mentioned, the first three objectives.
Right. Thank you so much. Thanks a lot. Can we connect to Dr. Marco, if possible, Switzerland? Hi, Dr. Marco, are you here?
Hello, can you hear me?
Yeah, just increase the volume, please. Yeah, Dr. Marco, just
Hello. One moment.
Yeah, we can hear you, but we can't see you, right? Yeah, we can see you now. Hi, how are
Hello.
you?
Yes, hi, good morning, Manish.
Yeah, good
I'm
morning.
very
Good.
well.
Just increase the volume, please.
Sorry. Increase. One moment. Yeah. It's better now.
I welcome Dr. Marco Trop. He is the founder and president of Trans-European Stem Cell Society, having a stem cell dedicated clinic by the name of Swiss Clinic in Switzerland. And we are in touch for last many years, although we have not
Yes.
till now. Hopefully this year from Sukkot, I'm planning to visit to him also, returning back. And so much, Dr. Marco, for joining here. This is the sixth batch which we are going to do the induction program, and this is already on. We have 6 fellows who are working on some projects, research projects, one of which was been just discussed, and rest of the 5 would be coming. So we'll be very much happy if you can also be a part of it. Meanwhile, over to Dr. Marco for his comments. Dr. Marco.
So, dear Manish, thank you very much for your kind words, and many thanks for inviting me to this esteemed panel. And as you said before, Manish, we are accelerating now to speed up our our capabilities to working together. And definitely we will meet in Switzerland soon. And one of the main focus I would emphasize now for the opening of this meeting or of is the importance of understanding that stem cell technology is not the future, especially in the orthopedics area. It's now. So that means that stem cells are now widely used for immunotherapies, especially in the treatment of tumors. Every one of you now should know that CAR T cell technology is now so much important for patients, and the big industry, like especially the Swiss one here, it's in my country, it's Novartis and Roche. They really invested a high number of investment money, really billions, to set up production sites for CAR T cells, also to focus their manpower on individual therapies with cells. Then the other area are iPS stem cells. 2 to 3 years, or even 2 years ago, it was not clear how iPS stem cells can get into therapy from bench to bed, and within a very short time distance, just 2 to 3 years. Now there are several research groups which are now starting with clinical studies to use iPS stem cells for neurological diseases, for heart disease, and so on. So that means the whole area is moving extremely quick, and we cannot talk, like I emphasized before, about future. And stem cells are very much important for orthopedics, or orthopedic usage because they have a very strong regenerative potential, as well as nobody knows better than you that with cartilage and bone repair, the immune system plays a very important role. And for example, mesenchymal stem cells, which are much more simple to produce and to develop compared to CAR T cells, are a very, very new and cool tool to use in the practice of orthopedics. And Manish, do I have 2 minutes to get a presentation, or is
Yeah, please go ahead.
then I have to share my screen? One moment, please. Okay. Can you see it?
Yeah, we can see it.
One moment, but I don't see it. That's the problem
No,
now.
no, yeah, there's some, it's not coming on
One-
the full screen. So maybe.
Oh. Something. Okay. So you can see it. Or it's one moment I have to
You can go for the slideshow mode, maybe.
yes, I have to go for one moment, please. The problem is I have so many things opened here. One moment, please.
Sure.
So, okay, good. Now you
Yeah.
can see it, yes?
Yeah, we can
Okay,
see it.
great.
Thank you. Thank you.
So,
Great.
it's just a brief overview on what TEST is. So TEST is a non-profit, and the Swiss Clinic is a profit spin-off of TEST. The idea is very simple: to get stem cell technology from the batch to the patient, to the bed. And we are very happy to work together with Manish on our projects. I really would like to focus here on MSCs because they have the biggest advantage in your area, because as I said before, they are easy to produce. Especially allogenic MSCs are very effective. And when we go forward here, safety and efficacy and evidence-based technology such as the MSCs are. These are the main points which are important to get this technology to the patient. As you know, there are regulatory hurdles in Europe, in the US, and in India as well. And these regulatory hurdles are problematic in a sense that it's much more easy to get CAR T cells now to the patients because the big pharma companies, they have the financial potential to get them through the regulatory processes very quick. The MSC area is struggling on one side, or is struggling on the regulatory side, because if doctors want to use it in the hospital or in the practice, it's the stem cell technology is on one hand evidence-based, but clinical studies are expensive. And there's not enough business yet that big companies getting to that point and to finance this kind of clinical studies so easy. The same is important for investors. They are also very careful with it. And so that makes it quite difficult for orthopedics just to use it in everyday practice for the moment. In Europe, you have stem cells are treated under advanced therapy medicinal products, ATMPs, and they are strongly regulated. It's the way MSCs are used in hospitals. They are now widely used, but still under exemption or as off-label treatments. And in clinical practice, what doctors are like to offer the patients is autologous MSC usage. But the problem is that autologous MSCs are not that much effective compared to allogenic MSCs. And this is underlaid by studies. Okay, this is just a brief overview. On stem cells, how they are gained and how they are used. On the right-hand side here, you can see iPS stem cells. iPS stem cells are strongly pushed, for example, by the Japanese government. So regulatory authorities in Japan have eased or downgraded the hurdles, the regulatory hurdles for iPS stem cells usage under clinical conditions. And this is something which is very much important for the whole area, and especially in Israel, our partner, it's Tal Dvir. He's starting now clinical trials with iPS stem cells to treat patients with neurological problems. So such as Parkinson disease, as well as patients which have undergone one moment. I see if I have. No, I don't have it here. So these are patients which have brain damage or which have physical damage in other neurological areas. And so what he's producing, for example, iPS-based cell patches. So that means he's using, for example, skin cells and transform them into neurons. And then he can build up, for example, cell-based patches from this 3D printer and put them directly into the location where the problem is. Okay, so the other important point I mentioned before is product safety and GMP practice, which is strongly linked to it. So MSCs can be produced very simple in huge fermenters. You can produce billions of cells. For example, there's a huge company in pharma company in Switzerland. It's Lonza. So they produce billions and billions, or can produce billions of MSC cells under GMP, which can, for example, immediately be used with patients. This is one example here for the usage of embryonic stem cells for a PD treatment in Sweden. It took 20 years to get the ES cells to the patient. And the same treatment you could get, for example, in San Diego at San Diego medical school, not medical school, at San Diego University in the medical department 10 years ago as a private payer. And so this shows again that the hurdles are extremely high in the stem cell area from the regulatory side. Autoimmune diseases are very strong target for MSCs. So we used to treat graft versus host disease in patients successfully. But I just would like to go quickly forward because I want to stress your time too much into the orthopedic area. So here you can see what we can offer the patients. So the patient can be offered treatment with allogenic MSCs, for example, on in the area of arthritis, rheumatoid arthritis. And the whole procedure is very simple. It's based on syringes. And here very much important is that, it's important to have a high quality of cells and to have the right number of cells and to put them into the location is a very simple procedure. And within 2 to 3 days, the treatment is done. The 2 to 3 days are important because you have to check out if there's no other kind of inflammatory problems with the patients. That's it. And the whole procedure can be done also in the practice. So it needs not a clinical environment to do it. These are some examples or references to underlay that MSC treatment with allogenic cells is evidence-based. It's an evidence-based methodology, and on this hand, it's on you, the doctors, the young doctors, to make pressure or to pressurize also the regulatory authorities to allow you more space for the usage of allogenic MSCs in clinical practice. This would be clearly for the benefit of the patient. So many thanks for
yeah, thank you so much. Yeah, because I think this last, your picture is remarkably very important, because in the clinical practice, we have seen many times that the allogenic cells work better, especially if it's an autoimmune disease. But for OA, still again a debatable topic. And we have this time doing some projects also on OA knee. And I think you'll stay there back, Dr. Marco, so that you can also hear what are the different projects, if you allow. Thank you so much. Thank you so much. So we'll wait for your more comments. So I'll invite now next Dr. Gautam. Dr. Gautam is working on PRP on partial acyl tears, most probably. After Dr. Gautam, we'll request Dr. Mohammad Ashik to come. So be ready on the line.
A very good afternoon to one and all here. Am I audible? Yeah, okay. So I'm Dr. Gautam Krishnan from KMCH Medical College, Coimbatore, as a senior resident in our Department of Orthopedics. And my topic on Feiora fellowship, the subject I'm taken is about ultrasound guided PRP injections versus a conservative treatment for a partial ACL tear. So the table of contents which I'm going to discuss right now is about introductions and aim of the study, a review of literatures, materials and methods, and outcome and ethical consideration will be discussed. So on a small introduction about ACL partial tears, uh, particularly partial tears significantly affects the athletic performances and the quality of life. So conservative treatment often fails, which leads to ACL reconstruction most of the time. So this platelet-rich plasma as an orthobiologic regenerative technology has emerged as a promising biological treatment with ultrasound guidance, which is very much precise and helps in targeting the PRP at the targeted site, and which also helps in enhanced healing and the recovery. So my aim of the study is to compare the efficacy of ultrasound guided PRP injections with a standard conservative treatment, which we have been followed for these many years with rehabilitations and physiotherapies, which either it is improving the pain and the function among the patients with partial ACL tears. So coming to some literatures which I've reviewed. So we all know as an orthopedic surgeons, we face a lot of challenges in diagnosing and treating a partial ACL tears. So in diagnosing, importantly in diagnosing with MRI to assess the tear location, it could be proximal mid substance or a distal tear, or it can be extent of complete ACL tear or involvement of anteromedial and posterolateral bundle. The most clinical and the most important diagnosing point is about clinical examination, which is very challenging, with a positive Latchman test and a positive anterior drawer test. And how do we approach? Basically, the approach for a partial ACL tear for these many days is conservatively managed, with either conservatively managed or if at all the conservative management fails and goes for a full rupture, surgically it is being done. So surgical management options like bundle specific augmentations and complete ACL reconstructions which was being done. So decision depends on extent and the location of the injury. So right now, so it's been practiced for the last couple of years maybe, where PRP as an emerging biological therapy, as a regenerative medicine PRP, which shows a promising minimal invasive options with enhanced healing in the cartilage and tendons and ligaments, which reduces the need for invasive surgeries. So what are the mechanisms of PRP and healing role? PRP contains such growth factors like platelet-derived growth factors, which promotes cell growth and repair, and transforming growth factor beta, which helps in regulating scar tissues and collagen productions. These PRPs stimulates the cell proliferation, migration, and differentiations, and also helps in modulating the immune response, and inflammation control is being done, and formation of new blood vessels. This TGF beta is a crucial in tendon development and early healing stage. So how do we prepare? I prepare in my college with the PRP, which has been prepared with the double centrifugation technique, and I take a patient's blood of around 60 ml in a 8 ml vacuum container, overall 60 ml of blood. In that, I receive around 6 ml of PRP, which is platelet rich. Platelet. Leukocyte rich PRP has been isolated, but in conditions where we can take leukocyte poor PRP, which is also a very ideal way where you're gonna leave out the buffy coat, where you can aspirate only the what is that, supernatant fluid, and then doing the second centrifuge and get the actual PRP of 6 ml. So my materials and methods for this study is, study design is a randomized control study. The study period is of 2 years. Population is patients with partial ACL tear who comes to the Department of Orthopedics in KMCH. The sample size, which I'm going to talk about, is.
I'll interrupt in between because there's a few things which we need to discuss before moving ahead.
Yes, sir.
First of all, your ethical clearance approval.
Yet to.
Secondly, now you're going just go to the backside. 2 years. Why you want to take for 2 years? Because this fellowship is only for 2 years. So it should be wind off in one end because you are just seeing, you are just selecting the patient with a partial ACL tear, right?
Yes, yes, sir.
Now you are giving how many doses? In which
So 2
schedule?
doses.
2 doses.
2
At
doses.
which difference? And how much difference?
At difference of 6 weeks.
4
weeks to 6 weeks period.
Fine. So you can get the result in a 2 or 3 months of time.
All right, sir.
So why to go for so much long? Because again, the publication will not be done, the work will not be done, your fellowship will be again going in.
I'll cut short it to be 1
So
year, sir.
just do it in 6 months of time.
All right, sir.
Finish it off later on and
All right.
publish the data.
All right.
First thing. Secondly, to all of you, I'll suggest still there's no standardization about which machine to be used, what is the calibration, what is the rotation, heart spin, what is the heart spin, soft spin. So I'll prefer that whenever you're using, please use REMI machine.
Yes, sir. We
Right?
have REMI machine.
Now, what we use is 20 ml of blood basically for a PRP, in which I used to get easily 5 ml, 4 ml.
Okay, sir.
Now you're taking 60 ml.
All right. Yes, sir. So it's a 8 ml tube where I'm going to take.
So which machine you are using?
REMI, sir. REMI R8C.
REMI, that is
R8C.
Okay, that is a cold centrifuge.
Yes, sir.
Fine.
Cold centrifuge.
So in the cold centrifuge, you can have that standard tubes which are 20 mls.
All right,
See what happened. Still in the literature, it has been mentioned that BMAC is a better choice for ACL regeneration partial tear.
All right.
Now we are going for a PRP, right? So that says itself is a good option, truly speaking, because that is more easily accessible and more easily to be done for the patients. So what I'll suggest is 3 doses at an interval of 3 weeks, PRP with a cold centrifuge.
Okay, sir.
Taking 60 ml of blood is too much from the patient.
Okay, sir.
So taking 20 ml of the blood,
all right, sir,
with a standard REMI machine with the tubes which they are having.
Okay, sir.
And then you can take a buffy code, which is obviously a little bit having a WBC content.
Yes, sir.
So that is okay. So that would be a better option.
All right, sir.
To go for it.
All right.
Because that study, so that nobody should question actually that anything has been, not been. And now, secondly, I don't know, I don't remember whether I've asked you for ultrasound guided or not, but USG guided is also a good option. But why we are taking a USG guided?
So to locate the exact point where I'm having a partial tear and.
Okay, fine. So see what happened. I think we all orthopedic surgeons know very well. ACL is a intra-articular but extra synovial structure.
Yes, sir.
So when we place our needle in, since he's using PRP, so definitely it's ultrasound guided is a good option. But
what I've done is for one patient, sir, I've done. So I took 6 ml of PRP. So basically, I got 6 ml of PRP. So initially, with an ultrasound guided, I injected 2 ml intra substance, and then 4 ml intra-articular.
But the intra-articular is not going to reach to that.
Definitely, sir. But still,
so what I feel is since ACL is a extra synovial intra-articular with the help of USG, definitely you're going to reach to the point, right? And the better would be to give inside only. There's no use of giving outside. So if you're using 6 ml, I'm sorry, 20 ml of blood, 4 ml of the content, placing inside, that will do.
Directly into the joint, you mean?
That will do. To the ACL.
All right, sir.
To the fiber, to the area.
But the thing is, sir, more than 2 ml, I'm not able to inject. The tendon get rupture and resistance. I could feel the resistance more than 2 ml. So I'm just stopping.
Plus, all these cases should be how much old?
40 years. Sir. I'll include it in the inclusion criteria.
Okay, fine. Please go ahead. And you're taking how many cases?
60, sir.
60.
30 with USG, I mean PRP, and 30 with the conservative group.
So if you are not able to manage 60, we can go for 50.
All right,
no problem.
Yes, I'll talk with the statistician.
So we want to be very authentic. We want to be very much sure. We have to review actually gradually also. And we need to have a good follow-up also.
All right.
So otherwise it will be of no use. No? Because
true.
And always these patients should be, what I do in my practice is, I never try to attempt a fresh ACL. Fresh means 2 weeks, 3. We have to give at least 4 weeks of time to see whether it is healing or not. So these things has to be taken care of.
Sure, sir.
Please go ahead. Sure.
Okay. So basically, I lock the knee in flexion, sir, 90-degree complete flexion. So what I'll do is I'm using a 10 hertz linear transducer, and I'll keep it parallel to the patellar tendon. Just keep it the transducer parallel to the patellar tendon, and caudally you just have to angulate 30°. Yeah, 30° with a caudal angulation. You can enter. You can directly see the ACL. Even if you're not able to pick it up, do anterior rod at the time. You'll be able to see a tear which is exactly pointing out at the
So
location.
you're using yourself only the USG?
Yes, sir. I'm having an ultrasound machine in my hospital. I'm
Now
using
the
it for
question arises that since we are doing a work which would be clear by ethical committee, we orthopedic surgeon, so PNDT Act is important. It's important for the
Yes, sir.
USG also, right?
Sure, sir. Yes, yes.
So when we're using, when
And
you are using a USG, you can't. I mean, how are you going to explain it up?
so basically, it's a hospital where I'm injecting these procedures in the OT, sir. I'm taking the patient to the OT. So minor OT where anesthetists used to use the ultrasound machines for blocks. So I'm getting help from anesthesia department, and they're giving me the ultrasound machine for this. So I don't think so that will be any
That
issues with
machine is that much is not appropriate, I feel.
hospital.
See, if I am as an orthopedic surgeon in my clinic, I'm using USG, I should have a PNDT.
Definitely, yes.
I should have a PNDT.
Even if I'm not using.
No, not for that is easier. See, PNDT is I do agree, but that regulatory thing has to be approved that I am supposed. Huh, okay, that's no problem. I mean, so your name is not coming. His name is coming, right? Truly. But I do agree with all the respect, but it is always better that you in the end you should write that USG is done by radiologist, not by you. What do you say, sir? See, it can be in the institution again. Suppose he's in the institution, so he can use it in the OT, but he can ask I mean, wherever the documentation is to be done.
Yeah, definitely, sir.
I think we had a discussion on this subject last week also, but there was no. I mean, I don't know actually. Any comments about? That mobile machine, is it sufficient having
Yes,
such a
sir.
capacity of the
Very
probe
much.
that it can?
Very much, sir. They have a both linear, curved, linear probes, every probes. It's the basic linear probe is fair enough to locate the tendons and muscles. iPhone, yeah.
Huh. But anyways, fine. Anyway, it is a headache of your ethical committee, your institution.
I'll get it done,
has
sir.
to
Not
be
a big
dealt by
deal.
them only. So it's none of my
get it
business
done.
in that way. But fine. Yeah, please go ahead. Yeah.
Thank you. Thank you.
Yeah. Here's the question. Yeah.
Yeah, yes, sir. Please go ahead. Sorry.
Just give the mic.
Yes, sir. Yes, exactly. So my studies, I'm including meniscal tear of grade 2. If I'm getting grade 3 and more, I'm not including.
So you're
patients
including
with
those cases here
only
also?
with, yes, sir. That's why I'll let you know in the
Yeah,
inclusion.
please go
inclusion
ahead. I
criteria.
think we can wait for a few minutes still.
It's a study of enrolled of 60 patients, as sir said, it can be up to 50 or 60 of the partial ACL tests, randomly divided into two groups. So there is PRP injection group, and the other one is standard conservative treatment group. So PRP injection group of 30 patients receiving autologous PRP injection under ultrasound guidance will undergo standard rehabilitation protocols, like all the rehabilitation protocol, which I'll be explaining in the next slides. And standard conservative treatment group will be receiving non-surgical management, including activity modifications, bracings, cryotherapies, and physical therapies.
These all patients are being selected after a duration of 4 weeks at least.
All right, sir.
It has to be mentioned.
All right, sir. I'll mention it that.
Because before 4 weeks, a conservative treatment may include a immobilization also, right?
Yes, sir. Yes.
That you have to specifically.
Definitely, I'll do that.
I think I have also already pointed out these things in the.
No,
we
sir.
were
This 4
discussing.
weeks thing, I didn't.
Anyway,
I'll do that.
yeah.
So in this phase of rehabilitations, I've calculated. I mean, I've divided into four phases: phase 1, phase 2, phase 3, phase 4. Where in phase 1, all the rehabilitations exercises programs include gentle flexion ROM, extension ROM to 0 degree, quadriceps and vastus medialis obliquus strengthening, and bilateral calf raises, hip abductions and extensions, and hamstrings strengthening exercises with electrotherapies. And in phase 1, it includes elimination of swelling, partial weight bearing to full weight bearing, and which is a 0 to 100 degree of range of movement, 4 plus out of 5 quadricep strengthening, and 5 out of 5 hamstring strength will be achieved. And in phase 2, which is much improved, which is up to knee flexion of up to 130 degree, full squat, and good balance and control. And then in phase 3, it includes full range of movement, full strength and power. Patient can go for returning of jogging, running, and agilities. And in phase 4, progressively, they can return to their sports activities. So inclusion criteria, mainly my patient's age should be between 18 to 40 years. Patient with history of knee injury within 3 months of duration, sir. So
you should increase the age. Why are you taking till 40? I mean, I don't have any problem,
right,
but it will be better if you can have 50.
All right, so because the problem is when I'm going more than 40, I'm able to see a lot of other
degenerative
changes. So
Fine,
I
no
can't
problem.
assure them with
True.
exact.
Agree.
No.
That you have to judge on your own part. I mean,
So that's the problem, sir. That's why I fix it with 40.
Fine.
And then patient with history of knee injury within 3 months of duration, and MRI diagnosed with partial ACL tear, and especially their platelet count has to be more than 1.8 lakhs.
Knee injury, which should be, just go back.
Sorry.
Knee injury, which should be at least post 4 weeks, 4 to 6 weeks.
Okay, sir. I've kept it as 3 months. I'll reduce it to 4 weeks then.
3 months will be very difficult for you to find it out.
Usually, sir, where I've encountered here is patient comes to me after getting treated with a lot of other doctors and all. They come to this periphery centers, and it will take merely like 1 to 2 months, more than 2 months. So whatever I've done till now.
Yeah, if you put on a range now, it will be easier.
I'll get it. I'll get it done. So 4 weeks to 8 weeks, I'll keep it as.
4 or 6 weeks, le lijiye.
All
6
right.
to 8, 6
All
to
right,
8, something like
done.
that. So you have a range now. That it will
All
be very
right.
difficult to partially diagnose partiality or platelet count less. Yeah, fine, okay.
I'm excluding.
Is it? I'm sorry.
Yes.
Is it important? We'll move very fast in a later presentation. Don't worry. Just go back. Is it important to mention the platelet content more than 1.5 lakh? Because I think all those who are doing the PRP, that's a basic requirement which is to be there.
Okay, sir.
You're getting my point. So if you want,
all right, sir,
you can mention, but 1.8 or it should be 2. 1.8 is so. It should be more than 1.8, right?
Yes, sir. That's what I was thinking. More than 1.8, ideally we can get into the power of 5 and around
fine. Okay,
10,
fine.
10 lakhs.
Please,
I can get it.
Please.
And in exclusion, I'm excluding patients MRA proven associated PCL injury, as sir asked, and grade 3 meniscal tears and grade 3 collateral ligament tears. And even with patients who received steroid injection within last 3 months, history of platelet dysfunction syndromes, malignancy patients, and with systemic illness, and HB of less than 10, sir.
And having any pre-arthritic conditions also.
All right,
sir.
All right, sir.
That's
why actually age of I kept the age of 40 years. That's why I kept the age of 40.
You should mention it here also.
Right? Okay, sure. So how I'm measuring the outcome. So basically 2 things. One for the pain, visual analog scale,
Fine.
and for the
Can
functional.
you move ahead a little because otherwise we'll.
Okay, so IKDC scoring system. And this is the questionnaires for 10 questionnaires I'm asking. So, and timed hop test is another functional outcomes analysis with the help of to assess the unilateral lower limb performance. And
when you are going to do this hop test?
At the baseline, and then 6 weeks, and then 12 weeks. So
A
I'll show you.
person who is having a partial
Baseline
ACLTR,
6 weeks and 12 weeks.
yeah, person who is having a partial ACLTR, we feel that he or she may be getting benefit out of it. 6 week is, don't you feel post 6 week is a little period which is
Post injection, sir.
obviously, yeah, post injection 6 week is a period which is very dicey, when even if some improvement has been there, we have a chances of getting it ruptured
Worsen.
again. So
So
what
based on pain scale, we can
Yeah,
grade it and we can go for it. If the pain scale is worsening,
so
I'm not going to do the
hop
functional
score,
outcome.
hop score can be because ultimately we have to document it that it has been regenerated.
Yes, sir.
And the clinical signs have been decreased. So we can omit hop score also, hop test also.
We can omit, sir. Okay. So only 2 scores. One is functional and VASC. All right. So my expected outcome in a PRP injection group will be having significant greater pain relief and improved function. And the VASC scores will be significantly improved from baseline 6 weeks and 12 weeks. So to conclude, ultrasound guided PRP injection is superior to standard conservative treatment in reducing pain and improving functions in partial ACL tear.
Whether we are going to do the post and pre MRI,
maybe after 12 weeks, sir.
we have to do it.
Yes, sir. After
That
12
is
weeks.
why I'm saying you just do 5 patients.
Yes.
It's fine.
All right.
But we have to at 5 or 6 weeks, when you are starting the cases, a tear which has not been healed, labeled, and after your intervention, it should heal.
We'll prove it, sir.
So that is why
I'll
I'm
add it.
saying decrease the number of cases does not matter at all. Even if 5 cases will do, but the proper documentation is very important.
All right, sir. All right. We'll do that, sir. Thank you. Ethical consideration, I'll get it done.
So
sir.
we'll
Yes,
get
sir.
into one month.
Yes,
one month
I'll get it
time.
done.
Thank you so much.
Thank you, sir. Thank you.
Dr. Marco, you are here. Thank you. You can clap for him, yeah. Everybody's. Dr. Marco, you are here for any comments?
Yes. So
Yeah.
yes, I think it was very well
Can we see him?
presented.
Can we see Dr. Marco
Yes.
here?
Yes, what you can
Yeah,
see me?
please. Yeah.
Okay.
Yeah. Any comments from your side?
But I have no major comments to yours. I think this was, I think you made the point. Yes.
Thank you so much.
Manish.
Yeah,
Yes.
because
Thank you.
sports is
Yes.
something which is more, you guys are doing a lot of sports, Marco, than us. So partial ACL is a very challenging situation where the
Yes.
patient later on go for a total ACL tear, and then that's the
Yes.
endoscopic surgery.
Yes.
Thank you so
Yes.
much.
Yes. By the way, Manish, I'm just writing a paper. You are invited to join on sports climbing injuries and the treatment.
Sure.
So,
With the grace of
so
God,
that's a perfect area for
go
it.
there.
Yes.
We'll come to you because
Yes.
this is our own baby, Indian stem cell
Yes.
text. So this work will be done in 1.5 years of time, and it will be presented there also. We hope for the best.
Yes,
Over to
absolutely. So,
Mohammad Ashik.
yes.
Mohammad. After this, Dr. Gokula. He is senior resident from ESIS Medical College, Chennai.
So good afternoon, everyone. So my proposed topic is going to be on using autologous PRP injection in transforaminal block. We are using this in the treatment of intervertebral disc prolapse. So this study is done under the guidance of Dr. Manish Khanna and along with my co-guide Dr. MD Kumar HOD in ASA Medical College. So starting with the introduction, intervertebral disc prolapse being the most common cause of low back pain with treated basically with epidural steroid injection for managing radicular leg pain, and steroid being most commonly used drug, and among steroid triamcinolone is the gold standard. But because there are some concerns in the literature which I quoted below, that epidural steroid injection can cause some neurological injury, neurotoxicity, and some effects like hyperglycemia, hypercortisolism, and adrenal suppression. And in rare case scenarios, it can even cause an hypothalamic pituitary adrenal axis suppression and can worsen osteoporosis. So one such alternate is using an PRP, which is an anti-inflammatory, anti-nociceptive, and has some regenerative effects on extracellular matrix. So it contains high number of platelets. We are going to centrifuge it and get a concentrated growth factor release from the platelet alpha granules, which is going to directly act at the target site. So it can have some proliferatory and anti-apoptotic effects on fibroblasts and neurons. I've quoted the reference below. So the rationale of the study is, one, we are going to explain the natural healing property of the PRP. Thereby, we can delay the surgery of intervertebral disc prolapse. And this is one more innovative method for the conservative treatment of IVDP. And the four, we are trying to consider the side effect of epidural steroids. And so the aim of the study is to conduct PRP transferrin injection for intervertebral disc prolapse. So this is a prospective study that is going to be conducted, and we included patients who are more than 18 years of age, who have had intervertebral disc prolapse at L3, L4, L4, L5 and L5S1 level, which is seen on MRI, and also have to correspond it clinically with symptoms and signs. And the pain level VASCO should be more than 5 with no prior spinal surgeries done, and the patient should have no optimal any improvement in conservative treatments, including any physiotherapy and medications.
So what is, just stay
Yes,
back,
sir.
please.
Yeah.
So what is the duration? Posterior lateral lumbar disc herniation for how long?
So for at least a period of 1 year, 6 months to 1 year, sir. More than 6 months will give, sir. Pain for more than 6 months, and they are being
See,
in
a patient of a PID who comes, who have a symptom,
Hmm.
they come to us, and if they are not going to get rid of the things,
Yes, sir.
definitely after 2 months of time or 3 months of time, they are still having a pain.
Yes, sir.
Because once you move to 6 months or 1 year, with this lateral disc herniation, there will be so much fibrosis
Pain.
and all the
Okay.
things would be there. The result will be very bad.
Okay, sir.
So the best would be to have the patient who have such injuries, such episodes, they have been treated by this and that, post 3 months.
3 months. Okay, sir.
Because 3 months is a pretty good period of time when the conservative treatment has failed.
Okay.
Now it has failed. Now, if you're going to leave this patient for another 6 months of time, later on it will be having more secondary sclerosis and all the things.
The result will
And
be
our aim of PRP is fibrinolytic activity.
Yes, sir.
So if you are making a fibrinolytic activity, why to wait for so much of time? So we have a documentation at 6 weeks, 7 weeks, rather after 2 months of
2
time
months and
that
3
we are having
months.
this problem. Get it done.
Sure.
Again, MRI is to be done to review it back.
To review whether the disc is
Fine.
ready.
So
Yes, sir.
yeah, please.
Can do that. So we are going to exclude the patients who have got any infection or undergone any epidural steroid injection in the past 3 months, or any other SNRV also with steroids. The patient should be devoid of any spinal tumors, tuberculosis, or multisegmental lumbar disc herniation, lumbar any spinal deformity like scoliosis or spinal stenosis, and the patient should not have any nerve damage, including motor paralysis, muscle atrophy, and cauda equina syndrome.
And one more thing. Now
Yes, sir.
I'll ask the exiting fellow. Batao bhai. One thing is missing here in exclusion criteria. Yes. Don't make my eyes to be shamed out. Because abhi aapne orthodermatology nahi padhi hai, so I can expect you. Yeah, we have to exclude spondyloarthropathy.
Yes.
That has to be excluded, because just now a person who is coming may be having a low backache for 2-3 months of time, just by putting a bucket and he or she has exaggerated pain, you label it as a disc, but she is already having a spondyloarthropathy.
Yes, sir.
So that you have to rule it out here.
Yes, sir. I'll add it.
Right?
Sure. So the study population is a patient who have met the inclusion criteria within the study period, and they'll be examined physically. A neurological examination will be done, and certain lab tests will be done. And the procedure is done in ESI Medical College, Chennai.
What is the study period?
So I kept it for the period of 1 year, and the follow-up is up to maximum 6 months.
Why to take 1 year? So suppose you're getting a patient, you want to give a PRP shot.
PRP,
So
sir.
how many doses you want to give? Single dose?
Sir, single dose PRP. Single dose
So
PRP.
what the literature says? Is literature is showing some evidences of single dose, or they are showing evidence of 3 doses or 4 doses? What?
A single dose, sir. We can wait up to the period of 6 months. If there's no pain improvement, we can go for second dose, sir. If there is some pain improvement, we can wait for a period of 6 months and follow it up, sir.
So what do you say? I think.
So
So-
far in a few
Have you
articles, I
have you gone
reviewed,
through the different literature which has been available?
yes, a few articles I
See,
went through.
again,
Sir.
there's a thing now. People are using PRP or people are using BMAC.
BMAC, yes, sir.
I think we are nobody is doing BMAC here, but in the last you're doing it. Last fellow, one fellow from the last year also did the BMAC. BMAC single shot will do.
Okay, sir.
PRP single shot will not do.
Okay, sir.
So I'm just placing in front of you. I don't feel the single shot of PRP will be able to do. What is your comment? At least 3 shots should be there.
Okay, sir.
BMAC a single
Yeah,
shot will.
absolutely, yes.
Yeah, yeah. Thank you, Dr. Marco. So you can have a 3 shots
Shots
of
of
at
PRP.
least 3 weeks of interval.
Okay, sir.
Post your 2 month of time, whatever it may be, so
Okay,
that you
sir.
can conclude it in another 2 months of time, and then a follow up. So the study
For
should
6 months. For
Yeah.
6 months, I'll follow
That
it
is
up.
okay, but
So,
the improvement fibrinolysis should be there within after at least 2 months within the last dose.
yes, sir. Yeah.
So your next MRI should be done within that period of
Yes,
time.
sir.
Then rest of the follow up. So again, you have to wind off everything within 8 or 9 months
Yes,
of
sir.
time.
So even if the pain is reduced in 1 dose of PRP, I can go for one more
Pain
shot.
is
or
nothing to do, dear.
Yes, sir.
Pain will be
So-
reduced by normal saline also. Pain will be reduced by
Okay,
Xalocan
I get
also, by dipomedrol also.
So we have to
want
look into the MRI.
just see that whether that disc is being degenerated rapidly or not. So 3 shot at the same time, get MRI done. Again, I'll say go for 5 cases only. That will do.
Yes, sir.
We don't require 100 of cases.
Okay, sir.
But that should be the procedure.
Sure, sir. So procedure.
So that is okay. I mean, we don't know.
Yes, sir.
You will take 20 ml of blood and
20 ml with
whatever it may be.
Yes, sir. So I'll just quickly go through the technique. In prone position, we are using fluoroscopy guidance, sir. So X-ray views. In AP, PA, oblique and lateral views. So 2 ml of lignocaine we are using along with 1 to 2 ml of dye, sir. Ioxol dye is being used here to
No, I'll
locate
say
the
why you're using lignocaine. If a anesthetist give us spinal anesthesia without a lignocaine, because again you're using either you can use a lignocaine outside only, because inside
Yes,
if you're
yes,
going
sir.
to use
Only
it,
on the skin infiltration, sir. Because since if you are taking any extra pricks, if you're not able to locate it properly.
Okay, so that you have to mention it here.
Yes, sir.
That
Skin
you
was
have to
injected, just
Correct,
skin, sir.
correct,
Skin was
correct.
injected. And we are using the dye to locate it, and 4 ml of PRP is used, sir. So this is the requirements. I'm using dye, PRP, and first I'm going to use only the local infiltration, and then going to the spinal needle. And this is a fluoroscopic image that I'm able to see an enhanced exiting node. So this was done in our setup, sir. So we're able to do.
And a pre-MRI has already been done, right?
Yes, sir, but I have not added it.
No problem.
here.
But it has been done, no?
Yes, sir, it's been done. So post-op, we are just evaluating for the neurology status 1 hour post the procedure, and we are following the patient at 1 week, 1 month, 3 months, and 6 months, sir. So the study period is for 6 months per patient. The patient is then advised to carry out their normal activities, but they should not avoid. They should not do any weightlifting, bending forward, and prolonged standing. And the scores for functional outcome, we are looking into VAS score, ODI scores, SLR, and SLR and Mngmt criteria. So these 4 are the scores that we are using. So VAS score, more than 50% decrease should be there, considering pre-op and post-op. And this is the ODI score, where the percentage should be reduced. If it's 0%, it means no disability, and if it's 100%, it means complete activity limitation. So this is the ODI score. Then SLR, we all know that 35 to 70 is degree suggested of disc prolapse. And this is the Mngmt criteria from poor to excellent. We are just comparing the pre-op and post-op. So statistical analysis, I looked through the prevalence of various articles, and I'm attempting to have around 50 patients. And data analysis is done to compare the pre-op and post-op. Then just go to the review of literature. So this, we all know that I'm taking 4 to 5 times of baseline platelets is present. And
50.
Yes, sir.
I think so we can decrease the number if it is too much.
Yes, sir.
Because 50 patient, every patient 3 doses.
Yes, sir. Yes, sir.
Why to go for it? We are not making any thesis here. Just do
Can
a
reduce,
genuine work which should be. I think 10 patient, 15 patient will do, 20 patient will do.
Sure, sir. Yes, sir.
See, guys, you just remember you have to present all these cases in front of me.
Sure, sir.
For the last 2 years, fellowship has been conducted in this interventional orthobiologics. अभी तक कोई भी fellow नहीं clear कर पाया है. 2 batches के लोगों ने अभी तक जैसे आपने apply किया है, they have also come here. I'm not going to clear it up unless until each and every case has to be placed in front of me. Be very sure about that.
So this is a review from various articles, sir. Then we have all have explained that improvement in the pain and decrease in the disc bulge following PRP injection comparing to steroids, sir. So these all studies have explained the VAS score and various other ODA scores, sir. Okay, so the expected outcomes of my study is that PRP can be a useful alternate for steroid in lumbar radiculopathy. No complications or side effects is so far noted in any literatures, and this will definitely improve the low back pain and other related disability. And MRI findings, there should be some reduce in the inflammation, sir.
In your exclusion criteria, diabetic patients should be also be excluded, uncontrolled diabetes. That
Okay,
is
sir.
very important.
Okay, sir.
Right?
Yes, sir. Fund control. Yes.
Any questions?
Yes, sir. So this is something that we are going to look forward. The cost
Fine.
effectiveness of PRP, long-term outcomes are to be studied. Complications in the long term is not seen in literature. And the lack of platelet quantification of PRP is not proper in many of the
Fine, fine. Thank you.
Sure.
One thing you must add that how do you analyze only the pain or anything radiological imaging or
We are going for MRI, sir.
yes, this
that's-
should be clear cut.
Yes, sir. So
The
MRI is
duration you
two-
should have to put this the how much duration you will follow up and how much you should do this.
So 2 months post the third dose of PRP, we'll take an MRI and confirm.
Fine. Thank you. Thank you. So now,
Yes.
Dr. Gokula. Yeah, Dr. Marco, I'm so sorry. Any comments from your
Yes,
side?
yes, very short because I see
Please,
that it needs to
make
work.
him-
The time. My question would be, you performed or there are conclusions which say, okay, that that the treatment was successful. So, but how you measure it? So it was not so clear to me. So how you prove that you got an improvement, for example,
Very
in
nice.
mobility or in pain?
Yeah.
That was not so.
Nice question, sir. Actually, till the PRP, BMAX, stem cell regenerative science was not been there, even then the patient was being treated. They were getting healed up properly. Our aim is just to prove that actually, I'll again repeat, it should be a BMAC, truly speaking, because that is having a bunch of growth factors and heterogeneous cell population, which will do the job of, fibrinolysis of that fragment which is out. That is why I asked him to go for a 3 set of PRP. The only way is if a person who is already having a 3 month of episode, non-diabetic or you diabetic, which may be controlled, all the exclusion criteria which has been there, still having a pain and MRI showing a disc, lateral bulge, which is being properly eaten up gradually after another MRI of 6 months, maybe the right document to prove it up. Truly speaking, again, the 3 month, the first case selection at the 3 month of time is again not a right case, because at least we should wait for 6 months of time to select a patient. But unfortunately, since we are using a PRP here, a very weaker device as compared to the BMAC, so we are selecting a duration of 3 months. But the only proof is a MRI.
Yes, sir. So we are going to assess the clinical outcomes with functional grades, sir. Then we are going into
Yes.
MRI to locate whether there is any change in the disc size. And we can also use the disc degeneration classification if at all is there any.
Okay, I see. Yeah.
Fuhrman classification can be used to know if the degeneration is improving to some extent.
And I think, Dr. Marco, you'll agree, till now, what the literature says that using a PRP or not using a PRP is the same thing. I mean, the literature is again
Yes.
saying it is a useless process. So we do
Yes.
agree that in this dilemma, we will again come, when we'll come to that forum, the spine surgeon will ask to us that, okay, no problem. I mean, it has healed by itself. What is the role of PRP? But at least we can try to do something.
Yes,
The best
yes.
would be BMAC,
Yes.
3 month, 4 month duration
Mm.
of the patient. But
Mm.
for starting the things, let's the ball started rolling with this thing. So that's why I'm asking you.
Yes,
This
yes.
is, with the
This is
pre
the point.
and
Yes.
post is important to get it published in
Yes,
an
sir.
authentic place.
Done, sir. Sure.
Yes, absolutely. Yeah.
Thank you so much. Thank you so much.
Yes. Thank you.
Good afternoon, sir.
Yeah,
This
Dr.
is-
Gokula, please introduce
Go-
yourself.
This is Dr. Gokula Krishnan from ACS Medical College. My topic is regarding assessment of functional outcome of platelet-rich fibrin in arthroscopically treated meniscal injury patients, sir. It's a randomized control study, sir. This is done under guidance of Manish Khanna, sir, and Naveen Jayaram, sir. The aim of our study is to document the benefits of PRF injection in the management of meniscal repair, sir. The hypothesis regarding use of PRF would enhance improved clinical outcomes like repaired in the repaired medicals and improve the functional outcomes, sir. Our research question is regarding whether the use of PRF will in meniscal repair surgery will regenerate the meniscus, and our hypothesis regarding augmentation of PRF will cause an improved functional outcome in the post meniscal repair patients. Our primary objective is to assess the functional outcome after PRF injection in patients with meniscal injury, and secondary objective is to determine the efficacy of PRF with arthroscopically treated meniscal injury patient compared to the arthroscopically treated meniscal injury patient without PRF.
So you are repairing the meniscus and then placing a PRF?
PRF.
PRF?
In one group and comparing with the only repaired meniscus in other group without PRF.
Okay, so what is your inclusion exclusion criteria in that case? Because that has to be very specific so as to compare it up. We can go back to the methodology later on. Just I want to see what is the inclusion exclusion criteria of yours.
The patient diagnosed with the meniscal injuries, the age criteria is from 18 to 55 years, sir. It's inclusion criteria.
Again, it will be better if you can decrease the age, because again, with the 55, you may be having degenerated knees also, no?
Okay, sir.
Why to unnecessarily get the people confused?
Our
So make it 40, 40, 45, because you want to take active persons. And it depends upon your hospital also. I don't know. I mean, if you can, that's a better alternative.
Okay, sir. Our exclusion criteria is prior knee surgeries and prior history of orthotomy and prior history of intraarticular steroid injection. These three patients are not
And
included.
any history of arthritis, right?
Okay. It's a randomized control trial, sir. It's a comparative study. We are having a sample size of 20, sir. And we are comparing two groups. One group with the after meniscal repair, we are augmenting with PRF. We are injecting the PRF, and another group we are not using the PRF. Both we will study, and we have a study period up to 18 months. At the interval of 6, 12, and 18 months, we will take a post MRI, and we will see the regenerative meniscus regeneration of meniscus with PRF and without PRF. We are going to compare.
So which type of meniscal injury?
Both with all.
I mean, there may be some bucket handle which you have repaired. There may be some other posterior horn which you have repaired. Which type of? Because that you have to take it very specifically, because the zones, the white zone and red zone is. So which type of injury you're going to take?
Vertical test. Vertical test.
Vertical tears. All of them should be vertical tears. Do you getting all those so many vertical tears?
No.
So that you see, you have to say medial later does not matter, but if it is a vertical tear, it should be a actually it should also may or may not be associated with the collateral ligament damage, but at least if it is a vertical tear, it should be all in the vertical tear in the same zone. Otherwise, how are you going to compare basically?
Okay.
Zone wise, you have to differentiate, na?
Okay.
So that is why I'm saying do less cases, but when you are going to present the case, nobody should be able to say कि तो अपने आप heal हो गया.
Okay.
Getting my point?
Yeah. No, post-operatively we will take MRIs.
Please take the mic.
Sir, sir, we are just repairing. There will be a sir. We are taking full thickness tear only in this criteria.
But
we are
in
just
both the cases, you are repairing.
Sir,
in both the cases, you are
both
repairing.
the cases we are repairing.
So what will be the criteria of regeneration? What you will be looking in regeneration? If it is already repaired, well, I am not getting the point that either it can be repair versus this PRF. Because
I am just augmenting, sir.
He's augmenting in some cases, he's not augmenting in some cases.
Some cases.
What he want to ask, if we are not, suppose he's not augmenting any cases, and he says he has got 100% result.
Okay.
Yeah, it's okay. So what you're going to compare about it? I mean,
Uh,
is the healing very fast?
Healing
Is
and
it
functional
more stronger? It's
Yes, sir.
more better?
Healing and the functional outcome, I'm just going to compare.
How are you going to measure healing? Duration?
Functional outcome, what will be your criteria? How you will identify
Sir,
that
I'll
it
go
is
for
healed well?
I'll go for the scorings and also AKDC scoring and visual analog scale scoring.
And that you have to do in a particular duration, that everything has to be done. Repair with PRF and repair without PRF, you will be calculating at XYZ duration
Yes,
particular.
sir. Yes, sir.
So, but for that, is it possible that in an 18-year patient you are doing with PRF and in 50-year patient you are doing without PRF? So there are multiple factors that will affect the outcome. Well, either you choose same age group, sir. Either same age group should be there, because with age other factors will also affect the healing. Age, the what that person is doing, the profession, everything will affect the healing. Type of injury.
You're doing a RCT, na? It will be very difficult to go for it. It's better not to go for a RCT. At least go for a simple. I mean, I'm not sure what the things can be. What do you say, sir? Yeah, prospective is okay. That is okay, but don't go for RCT. It will be very difficult.
Okay, sir.
It will be very difficult. Just prospective study. See, what we hear with the other arthroscopic surgeon ki bhai PRF laga diya, healing was very faster. A patient who is diabetic, see, suppose I am an arthroscopic surgeon, I do a lot of repairing. In what cases I feel challenges? When the patient is obese, diabetic, lot of other things are there, injuries there, then I know, oh, I am going to fail. Here I am going to get a recovery by PRF, adding PRF. So that you have to consider in mind while attempting for a work. Is it been, have you, who's your guide there?
Sir, Naveen. Naveen.
Okay, Naveen, okay.
You should be specific. Whether you are going to do this red zone, red white zone, or the white zone.
Okay.
This is the thing that you can mention. This red zone, this will definitely heal.
Okay, sir.
Red white zone, they may heal or may not heal, but white zone, they may not heal. You just clarify this is this zone wise.
Okay, sir.
That will make you easier, because no orthoscopic surgeon will repair in white zone. They will always make it the meniscus balancing. So this is the thing that we can approach, that this thing should, whether it is working or not.
Okay.
If it is not working, you can say this is not working.
Okay.
You just specify it by zone wise. I think this will be good.
So that would be the best. The zones where we are very much apprehensive in operating and repairing, that you have attempted by PRF. Then you can say the literature says this thing, and I am presenting this thing. So that prospective study should be there.
Okay.
There you have to make entire changes actually.
Okay, sir.
Right? Otherwise, this all activity of your coming here will be wasted.
Okay.
Yeah. Please
Okay.
go ahead.
The calculated sample size is 16 and 8 per group, and I have taken 10 for if any loss of follow-up is there, and I plan for randomized control still. I'll make changes and going for prospective studies.
And this whole thing is being recorded. It will be available in the YouTube.
Okay.
So you guys can discuss with in your college, in your institute about the discussion which we had. So there's no need to, work it up in that way, because
Okay,
this is a panel of discussion which we already are doing on this
Okay,
matter.
sir.
Yeah.
It's a study duration is around 1.5 years, and 18 months from the date of approval from the ethics committee. And my method of collection is collecting 20 ml of venous blood from that from patients, and one spin, one centrifugation, 1200 revolutions for 8 minutes is my in the Remy machine.
You have taken 18 months. This is again a very long duration.
So 1200 revolutions for 8 minutes. 8 minutes.
If you are repairing right now today in a white zone where the repairing is not very good, and you're getting a good result in a 2 months or 3 months of time by MRI, whatever functional outcome is there, that's fine.
Okay.
That's fine.
Okay, sir.
Because I'll not name the fellows. Jitni studies we are going to do along now, you're not going to complete the fellowship.
Okay.
And what is the use? I mean, see, at the next level, you can present another work that a long-term follow-up of 2 years. But right now, we just want to prove that it is working or not working in those zones. That's all.
Okay, I'll reduce
So
the
6
duration.
months would be a perfect time.
I'll reduce the duration.
Yeah. 6
No,
months and 6
PRF,
months
sir.
follow-up. Yeah.
PRF, not PRF.
PRF.
PRF. No,
That is a
same
platelet-rich fibrin.
fibrin.
So you don't mix anything, take the blood and just go for the centrifugation. A plug of fibrin has been there and you place it there arthroscopically.
It's a clot.
Whatever the procedure has been done.
It's a clot.
And how much immobilization you are, because see,
For
after what is the usual protocol
Sorry, for
after a surgical repair of meniscus?
after surgical repair, we just we'll use a knee brace for 6 weeks for.
And what about the range of motion?
Range of movements, knee flexion. We will start on full weight bearing after meniscal repair, and up to 6 weeks, 30-degree knee flexion is.
So now again, you're able to do require a full weight bearing right now here because the fibrin has been there and you want it to stick out there for some time.
It's a clot, sir. Chance of discharging will be less when compared to PRP, so we can start full weight bearing also.
So in your usual practice, you immediately ask the patient for a weight bearing.
Weight bearing. Up to 30-degree knee flexion will limit to 30-degree.
I think it should be not before 6 weeks. I mean, how can you repair a meniscus and ask the patient to go for a full weight bearing? I'm not able to understand.
Okay. Sir.
Yeah, please.
Okay, sir. Sir, after 6 weeks, we will start on full weight. Knee flexion up to 30-degree will allow, and full weight bearing after 6 weeks.
You just go to the literature.
Okay, sir.
What they have done.
Okay, sir.
You come back again to me later on individually, sometime on the Zoom, we'll discuss and then we'll formulate, because there's so many lacunas here. It'll be very difficult to work it up.
Okay, sir.
Right? Yeah.
Sir, my
and ethical clearance then,
ethical
right?
clearance is
Yeah,
pending.
fine.
Okay.
Thank you so much.
Thank you, sir.
Thank you. Yeah, Dr. Marco, any comments from your side, sir?
Dr. Manish, no, thank you very much. So I think your comments have been also perfectly on the point. So
Yeah, because the weight bearing was been the most challenging, and the zones. I think we were discussing, Marco, on this subject few weeks back now, of the types of patients which you are getting there also. So same challenges, same needs, same human nature.
yes, yes.
The zone wise, we face the same challenges everywhere.
Yes, but I think when you use, for example, this kind of blood as a PRP, if you use this kind of material, the problem very often is really the quality, and the quality is driven by the quality of the patient's health, and that's one of the problems. So and that's also a problem for the standardization of that kind of methodology. So if you have a patient which is obese and you use his blood for this kind of treatment, then you will have probably totally different data compared to a healthy and sportive person.
Yeah, true.
It's not only the weight; it's really the age which is coming into the quality of cells is getting worse with age, even if the person.
Yeah.
And that's the reason I mentioned before, or I stressed out the usage of allogenic MSCs. And I think here in all cases, because what you use, this is really a very, very good standard used on a high level, also
I do agree.
in hospital. Yes.
Yeah, I do agree, Dr. Marco. Definitely, MSCs are the best, and even the autologous or the allogenic. But since we are doing a work in front of everybody, we just want to re-emphasize on this point that regenerative science works. So that is why PRP or BMAC. But definitely, yes, it will take I down the lane, maybe after 5-6 years, we can directly ask the persons to go for a BMAC or a MSc, because that will be doing a lot of wonderful work, truly speaking.
Yes. Yes, absolutely. Yes.
Yeah, thank you so much. Yeah. Next, Dr. Mir. Then Dr. Vaibhav is left and only you are left now? Only you. Dr. Mir is from Hyderabad. Yeah, introduce yourself, Dr. Mir. Once again, please.
Good evening, everyone. Myself, Dr. Mir Misbauddin. I'm from Hyderabad. Uh, Today, I'm presenting regarding this evaluating bone marrow aspirate concentrate versus this platelet-rich plasma for the knee osteoarthritis. It's a prospective analysis. Coming to abstract, knee osteoarthritis is a prevalent degenerative joint disease characterized by chronic pain and functional limitations. Emerging biological therapies such as bone marrow aspirate, concentrate, BMAC, and platelet-rich plasma (PRP) have shown potential in modulating inflammation and promoting the tissue repair. This prospective study investigates and compares the safety as well as the efficacy of BMAC and PRP injections in patients with mild to moderate knee osteoarthritis over a period of 12 months. OA of knee represents a major cause of disability worldwide, especially among the aging population. Current treatments include NSAIDs, corticosteroids, hyaluronic acid injections, which provide symptomatic relief but do not address the underlying degenerative process. So, orthobiologics such as BMAC as well as PRP are increasingly explored for their regenerative capabilities. BMAC contains mesenchymal stem cells, hematopoietic cells, cytokines, as well as growth factors, while PRP is rich in growth factors such as PDGF, VEGF, and TGF beta that are involved in healing.
Don't mention BMAC as having MSCs. They are having a negligible MSC, so better would be to mention it is having heterogeneous cell population, right?
Sure. Both these modalities have been independently shown to improve clinical outcomes in the knee osteoarthritis. However, head-to-head comparisons remain very limited. So our study focuses on those comparisons. This prospective study aims to evaluate the comparative efficacy and safety of intra-articular BMAC as well as PRP injections in patients with Kelligren-Lawrence grade 2 and 2 to 3 knee osteoarthritis. Coming to the objectives, our primary objective will be to assess pain reduction using the visual analog scale VAS and functional improvement using the Western Ontario and McMaster University's osteoarthritic index WOMAC index scores at baseline at the time of injection baseline 3 months, 6 months as well as 12 months. Coming to the secondary objectives, to assess the patient satisfaction and quality of life via the SF36 questionnaire to monitor adverse events and safety profiles for both the treatments. Coming to the materials and methods, it is a prospective study, randomized, controlled clinical trial. Duration will be at baseline 3 months, 6 months, as well as 12 months. To complete tenure will be 12-month follow-up. Location is single center tertiary orthopedic institute. Coming to the inclusion criteria, age will be between 40 to 75 years. Diagnosed with symptomatic knee OA with KL grade of 2 to 3, BMI less than 35, no prior knee surgery in the past years. Exclusion criteria will be advanced OA with grade 4, autoimmune or systemic inflammatory conditions, or current use of immunosuppressive therapies, or active infection or malignancies. Coming to the protocol, patients meeting the inclusion criteria will be enrolled after informed consent. Patients are randomized into 2 groups, BMAC and PRP, using computer-generated sequencing in 1:1 ratio. Coming to the preparation, 60 ml. I was planning to take, sir. I'll reduce it to 20 ml.
And secondly, you're taking how many RCT, how many patients in both the groups?
20, sir, 10 each.
10 each. Okay, that's fine. That's fine. Duration is 6 months or what? A single shot of PRP?
No, sir. I'll be mentioning 3 shots of PRP.
PRP and single shot of BMAC.
Single shot of BMAC.
Okay, fine. And what about the any MRI? Anything which you
No, sir. Only my objective pain reduction. My main objective will be about the pain reduction. Using
and you want to prove that the BMAC has a more better pain
Yes, sir.
reduction as compared
Yes,
to
sir.
a PRP.
Yes, sir.
Can't we go for a MRI pre and post? Is it possible? You're in some
private medical practice, sir. So
Okay,
MRI
it will
won't be
difficult
that
for you.
feasible.
Is it will be feasible for you?
No, sir. MRI won't, post treatment MRI won't be feasible. So I'll be losing more follow-ups also that way if I advise
Fine,
MRI.
fine. Since fine, it's okay. But otherwise, actually, we still are waiting to
Arthrogram.
get it proved. There is one consultant in Delhi also. I don't remember his name. He's an Indian Stem Cell Study Group member. He has done a lot of BMAC in OA knee, and we wanted to prove it that the by cardiogram that regeneration occurs, but we were not able to go for it. So I mean, definitely yes, for a true study it is good, but otherwise we are still lacking behind on that part. Yeah.
Apart from this, I can try, sir. If at all some patient goes for an MRI, we can plan for
At
a
least
separate
yes,
study.
you should have a pre and post at least in some. See, even if we are going to publish a case study of 5 cases, at least level 5 evidence can be created.
Sure.
Something should be there where we can prove it up. So since you're doing BMAC, I'll request you at least 2 or 3 cases you can go for a pre and post.
Sure.
I know it's difficult for getting a patient for a post MRI, but I'll suggest it in a private setup. I think we have at everywhere 2,500 they 3,000 they get it done. So if you're going to charge for 6,000 rupees for MRI and just keep 3,000 rupees in your pocket to be used later on free for the patient, it will be better.
Sure.
We need to document actually.
Sure.
Cardiogram.
Coming to the preparation of BMAC, posterior iliac crest
Fine,
will
so
be
there's no need to discuss in that way. So you're using a BMAC, again using same machine, REMI machine,
yes, sir.
and that will be same REMI centrifuge for both the things together.
Yes, sir.
So here using a posterior approach, PSIS approach,
Yes,
and 60 ml you can take it out. Whatever.
Yes, sir. 60 to 120 depends.
And how much you're getting the content? 8 ml, 8 ml.
Yes, sir. 10 ml. Coming to the injection administration, all injections either ultrasound or C-arm guided into the knee joint. Frequency PRP group 3 injections at 2 weeks intervals.
I don't allow you for ultrasound CM guided. Just go for a blind. Because see, we are using so much sophistication for a general orthopedic surgeon. It will be very difficult. In ACL, it is okay. We want to target it.
Okay.
So cells or the content, they reach to the site wherever it is required.
Okay.
So if you're using a 6 ml or 8 ml of 5 ml, you're using a BMAC, right? 4, 5. It's fine enough. Or 6 ml of BMAC is again fine enough. There's no use for going for ultrasound or C guided. Don't go for it.
Okay. In BMAC groups, only single injection at baseline. Post-injection care, avoiding NSAIDs for 2 weeks post-procedure. Use acetaminophen as required. Activity modification for at least 3 to 5 days. Patients are assessed at baseline 3 months, 6 months, and 12 months post-treatment.
You're going to reduce it now, no?
Okay, sir. Last 6 months and 9 months. Assessments include WAS and WOMAC scores for pain and function. For pain and for function, SF36 questionnaire for quality of life. For adverse events tracking must be done in these cases for both PRP and BMAC, including infection, swelling, or persistent pain.
So just remember that in BMAC, usually if the patient responds very well, for next 1 year, the degeneration and all the process stops very well. So 1 year of duration is okay. For PRP, okay. By that time, they again requiring it that you have to prove it up otherwise also. And secondly, one thing more. Forget about the cardiogram and the knee MRI. A simple, good X-ray also demonstrate that the changes have been improved. There's no need for going for a MRI. If you can document in your BMAC all the cases, the X-ray changes, PRP may nahi milenge. The PRP will not get X-ray changes, but in the MRI, if you ever get, in a OA, if you're getting a right case, it will be having it. And please select the cases only after We'll start the orthorheumatological part of study because you have to differentiate that this is a patient of OA or CPPD knee, because again, you have to find out where you're going to act, because on those cases, if it is a OA, is going to work. If it is a case of a mild undifferentiated arthritis, it's not going to work. So the failure rate will not be because of this BMAC. Failure is because of our diagnosis, right? Yeah, thank you.
Thank you.
Dr. Marco, any comment, please?
So far, Dr. Manish, I've no further comments.
Yeah.
Thank you.
So much. Thank you. So now we are going to the last candidate, Dr. Vaibhav Jain. So by this, we'll wind off everything and then we'll have a closing event.
Good afternoon, everyone. My topic is functional outcomes of intra-articular platelet-rich plasma therapy in sacroiliitis. Sacroiliitis, as we all know, is inflammation of the sacroiliac joint, which may be due to ankylosing spondylitis, infection, trauma, or due to postpartum in a postpartum period. It causes severe low back pain, functional impairment, and standard treatment include NSAIDs, physiotherapy, corticosteroid injections. Limitation is of all these treatment is temporary symptomatic relief. So we have all been discussed. It has been discussed in all the topics why PRP and how is it works. So I'll just skip it. The study objective is to evaluate functional outcomes of PRP therapy in sacroiliitis by seeing pain reduction, improved joint mobility, and overall functional recovery. Study design, it's a prospective clinical study. Duration of study is 1 year. Participants age included between age 18 to 60 years with confirmed sacroiliitis with failed conservative management of 4 weeks. Exclusion criteria includes systemic infection, malignancy, coagulopathy, and prior SI joint surgery. PRP prepared from autologous blood is standardized centrifugation method by using Remy machine. CM guided intra-articular injection into the sacroiliac joint. Preparation has also been discussed. So I'll be measuring pain by visual analog scale, functional by ODI, follow-up at baseline 1 month, 3 months, and 6 months. MRI to see inflammation evaluation and changes in the joint at baseline and post procedure at 6 months. Statistical analysis, paired t-test, paired measure ANOVA significance level at p less than 0.05. Expected outcomes include significant pain reduction, improved mobility and daily activity performance, reduction in MRI signs of inflammation, potential long-term disease control. Institutional ethical clearance will be obtained. Informed consent from all the patients, and patients' confidentiality and safety are prioritized. PRP could be minimally invasive alternative for sacroiliitis management, potential to reduce long-term medication and corticosteroid use, better functional and clinical outcomes. ZUAS and ODI. Thank you.
So you're using PRP in sacroiliitis. Yes. So what, I mean, in your exclusion criteria, you have not mentioned that whether these patients are having any inflammatory arthritis or not. Why we are using, because all these orthopedic orthorheumatological surgeon will say sacroiliitis, yes, Dheeraj, sacroiliitis, and maybe undifferentiated arthritis with good sulfur salicin, everything the things will get rid of. अभी क्या जरूरत है हमें PRP करने की? So just yeah, what is your?
So my main objective is to see whether we are seeing any joint changes in post-op MRI, because as you have said, I am facing the problem. I have started seeing the patients and giving them trial. Most of them are getting improved by SARS and conservative treatment. So I'm finding.
So you want to have an improvement in radiological changes?
Yes, sir. I want to see the radiological.
That makes the sense.
If it's not there, then
so
it's
definitely these patients have to be taken in the line of orthorheumatological practice of all the management, whatever the management is to be done, plus radiological changes, which we don't find after giving simple DMRDs. Yes?
Yes, sir.
Anything?
I just want to add one thing.
Not all patients.
Sir, are we giving SARS to the patients or any other DMARDs to the
Yeah.
patient initially?
In diagnosed ankylosing spondylitis patient, we are giving SARS not in the postpartum period or a traumatic.
So we are giving SARS and we are giving PRPs in those patients.
No. Yes, plan is that after giving DMARDs and conservative treatment, if they are not responding to the treatment, we will be giving PRP. But I am facing
And
the
sir,
problem.
वो duration कितना होगा for the DMARD therapy? Because once the if the prolonged duration has been crossed, the joints will already been affected. So the reversal of by PRP, will it be possible?
No. In grade 1 and grade 2.
Yes, sir.
SI joint changes.
Okay.
Grade 3 and grade 4 will not give any. They will not have any space.
So we are including only grade 1.
Grade 1, grade 2, Angstpon, early diagnosis in postpartum period and traumatic, not in infection.
Okay, sir. Thank you, sir.
Spondylitis, conventional DMRD like sulfasalazine, it's an axial disease. It will not work properly.
So that's another topic. That's yes, SARS and all those things. And I think I have explained you multiple time in the lectures also. It works very well.
SARS is giving.
It works very well. SARS works very well in a young patient having a ankylosing or undifferentiated, whatever it may be, SI joint inflammation. It works. Yes, we are not entering into that dilemma that whether SARS works or not. But the only thing is, if a patient comes to me with the ankylosing spondylosis or whatever anything with the SI joint changes, I never give PRP. So I never appreciate any improvement radiologically which you want to have it,
Yes,
right?
sir.
So that you have to do a very good patient case selection. That is
Yes,
very important. But again, I will only allow you to present if you have if you prove it up that it has some improvement. It will happen. So depend upon the cases. Now PRP in a SI joint is I think everybody like is not very easily accessible. So you have to be, with the fluoroscopy guided, you have to go for it. You have to select a site. And in fact, the upper portion or lower portion, whatever you want, you have to select only those patients.
Okay.
Right, sir?
Sir, I think ankylosing spondylitis should not be taken into this study.
Yeah, it should not be taken.
Because you are not controlling the disease. You are just controlling one of the symptom, and if the disease is there, again it will affect the joint.
You just mentioned your 5 patients were from this disease, AS. See, Dr. Dheeraj, I think he has to mention that he has given, actually, truly speaking, I think we were just discussing a few minutes back. As you were saying, if I start a particular drug, patient is not responding, then you give a PRP. My way would be, if I give a drug, patient not responding, I switch it to another drug. See, we have to take care of 2 things. Disease progression should be stopped and the radiological improvement you want to have. So what I feel is all those cases who are responding well to my treatment is still having changes, that should be attempted. What do you say?
What I was saying was that he is treating sacroiliitis because of ankylosing spondylitis. He is not treating ankylosing spondylitis.
No.
So giving PRP in an AS patient might have a short-term result because disease activity won't be lowered. It is there. So I think that ankylosing spondylitis should not be taken into consideration because that will.
So
be
what should be taken?
No, I don't know what should be taken, but ankylosing spondylitis will
and
definitely
this
give a
is the
bias.
this sacroiliitis. We have found this in the accidental finding of a MRI who have not that much symptom. One scenario. Another scenario is that the patient is having ankylosing spondylitis and he is having this joint inflammation. So the patient should be with the medicine. He cannot stop this medicine because due to this SI joint injection. So it is both the thing will be simultaneously happening here. The patient who is having SI joint problem, he should have a systemic problem.
Yes.
So he should be with the medicine. Then it is always a adjunctive. That it is not that it is the only thing and the medicine should be stopped.
No. What I'm saying
This
is that
two is the
there
simultaneous.
should be some duration of expected outcome.
Only thing that you can expect that if there is any change, radiological change, as sir is saying that there is any radiological
That
change
change
after
won't
this
be
injection.
permanent, sir, because the disease activity will increase because
So
PRP
this
will
is
not affect the
much,
disease.
I think so.
So maybe after 3-4 months again the same condition will appear.
Can't we go for a BMAC then a PRP in this?
So cost effective.
Okay, you're in some institute, na?
I'm in GMC, sir. Gandhi Medical College.
Gandhi Medical College, Bhopal.
Yes, sir.
But you have a centrifuge machine already.
Yes, sir.
So the cost will be the same.
So I'll be reading about it. I have not used BMAC till now. In any case.
See, actually, what Dr. Dheeraj he is trying to present is the functional outcome. See, it is a very debatable topic. We can't prove it for next 5-10 years that the changes have been cleared up by sulfasalazine or a drug or by a PRP. So better would be a BMAC, a single shot, because again, वही problem होगी ना, PRP single shot will not do. A single shot of a BMAC in a patient who is settled. See, to me, if you ask me, I'll select a patient in my OPD who has a SI joint involvement, right, with the ankylosing, any damn thing, and the patient is now settling down by the CRP ESR. That is for the orthopedic rheumatology, which we are into in actually. आपके पास भी 2 साल का time है, कोई कम time नहीं है. So you should select a patient who is having. There does not make a difference that even ankylosing spondylosis patient has been selected, because you have to treat that patient properly. Show to the audience that look, these changes are been there. I have given a single shot of BMAC and the improvement has been there. That makes a sense actually, rather than for a PRP, because PRP single dose will not going to do anything. Over to Dr. Marco. Dr. Marco, you want to say something, please?
I think because you have to see how much activity you have, which is able to reduce not only the symptoms, and this would be also my question. So how many MSCs you have in one shot you give with, for example, with BMAC or with PRP, And I think what we see in practice is that the number of MSCs you use, for example, in rheumatoid arthritis, the number of cells you can applicate to the patient is very much important. So normally you need 1 million cells per kilogram of a patient to see effects. So that means you put in a shot of 60 to 100 million cells into the patient for 2 to 3 times, and then you can see improvement, And I think here it's a similar condition from my point of view.
Very true, very true. You are very true, Dr. Marco. If a patient come to me, I would love to inject 50 million of MSCs and SI joint to get an improvement done, but that will require Indian rupees of 50 to 60,000 rupees, for which the patient
Yes,
are not
that's the
interested. We are
problem,
also not interested.
Yes.
That is why we are just trying to explain the word that the things are working. That is why I'm always again saying, do 3 cases, show the result, that will do.
Yes, absolutely. Yes.
So the best would be,
Yes.
would be to have a PMAC, dear. I'm always available 24/7 anytime. We will select the cases, do 3 cases only, does not make a difference. And the case selection should be, the patient should be a settled patient of a,
that will be better.
Yeah. The only issue is about the cost. So if you're in an institute, the BMAC will not cost. The injection shot will be only the thing. And that should be the first thing you should explain today only to the patient. Look, I'm starting the treatment. After 2 months, I'm going to give an injection to you, so that he or she should not refuse it. Right? So thank you so much. Thank you so much, Dr. Marco, for your presence, kind presence. A big round of applause for everyone.
Thank you very much for the invitation, and
and
I'm really pleased, really, on the
Dr.
work
Marco,
you do. Yes.
Be here with us. Don't go, because this time, for the first time in the last 5-6 years, we are not able to distribute the certificate, but now today the registrar has given the signature. So we are going to go for a cake cutting ceremonies of the pass out and certificate distribution also. So you should be a part of it. It's not being here. It is in the other hall. I'll request, is it possible he can join? Okay, you can join it there.
When is it? In which time?
Just 2 minutes. Just 2 minutes. Stay back.
Yes,
Please.
no problem. No problem. I reserved the time.
Dr. Dheeraj handing. Fine. हो गया? They will come. But why should we be replaced completely? चलो चलो चलो
सामने लगेगा, सामने लगिए।
So I will be announcing the name one by one. So I think all of you now come this side, and we teachers will be there. Sir, please come. Dr. Partha, you are here. So we'll be starting with Dr. Pranal.
सामने लगेगा।
Dr. Muthu. Dr. Kana. Dr. Arijit.
सर थोड़ा सा
Dr. Hardik. Dr. Hardik has scored the maximum marks in this batch. So next time his punishment is he has to come here. Like Dr. Dheeraj has come here. So it is not a punishment, it is a pleasure. Dr. Vinay. Dr. Sinha. Please join us for a group photograph. So this is now fifth batch completed, and till now 70 Feiora candidates have already been passed out by us. So which the number will increase gradually so as to have a more better quality has been decided by the committee members. But definitely we'll go ahead. Please come in. For a group photograph for exiting batch, inducting batch, as you know, always. First we can have all together. Yes.
थोड़ा सा ठीक से सेंटर से जाओ पीछे आओ भैया सामने लेके
Thank you. Now we can have exiting and just move out and come after. One last picture. Please come for the tea. There's banner in front of you. Anybody want to take the pictures? You're most welcome. Yeah, okay, thank you so much. We'll be in touch. And yeah, thank you so much for taking out your precious time for us.
That's very much important.
Yeah, thank you so much.
Yes.
Yeah. Okay.